Yeah, so good evening, everyone. I'm Dr. Sai Kumar. I'm president of the Cochin Ophthalmic Club, and welcome to this third module of Ophthalmology Reboot. We had two modules today, one on glaucoma and the other one on pediatric ophthalmology, both very well attended, about 2,500 viewers for glaucoma, nearly 1,500 viewers for pediatric ophthalmology, which I consider is a very, very good number. And hopefully we'll have even more attendance for the retina on Saturday evening. With these few words of introduction, I request Gopal to just introduce the learned speakers to the audience. And on my behalf, I welcome Lalit sir, Dr. Mangat, Dr. Giridhar, all the senior, retina people, Dr. Meena Chakrabarti, and to this meeting. Thank you for taking time off on a Saturday evening to come to this meeting. And Gopal will now formally introduce the speakers in a few words, and then Manoj will take over. Gopal, you are muted.
Thank you very much, Dr. Sai. It's been an immense pleasure to invite all of you to this platform of Ophthalmology Reboot 2020. Here we are over 2 days of 18 hours. We are trying to attempt to have a go at the complete ophthalmology, 360-degree ophthalmology refresher program for practicing ophthalmologists as well as postgraduates. And as we would say, the topics covered in retina in this particular session will actually have to be done over 2 days. Unfortunately, we have to short it down to about 3 hours. And so when we are covering 360-degree of retina, make sure that we basically stick to time and so have some time for discussion. And I would like to, invite Dr. Lalit Verma first. He is the course director along with Dr. Giridhar and Dr. Meena Chakrabarti, who are our course directors for this program. And moderator would be Dr. Manoj S. from Chaitanya Eye Hospital, Trivandrum. The first talk would be by Dr. Mahesh, and then followed by Dr. Srinivas, Neha, Anand, Raja Narayan will join us, then Giridhar sir, Mangat Dogra sir, Dinesh Talwar sir, Meena Chakravarti madam, Prashant Bavankule, and Rajesh. It's a star-studded group, and I now invite Manoj to start the proceedings.
Thank you, Dr. Gopal, and thanks for involving me in this wonderful meeting. Let's start with the proceedings right away. The first speaker will be Dr. Mahesh. He'll be speaking to us on OCT and OCT angiography. Dr. Mahesh.
Thank you, Manoj. I'm just trying to. Yeah, okay. I have written OCT and OCT angiography postgraduates because I thought it will be some basic course which not to the level of high retina discussion. So OCT, in fact, is just like a stethoscope is there for a physician. And we can't do away with OCT in our regular practice. In many of us even see the patient after seeing the OCT. So that is the situation now. It has become available everywhere in India, and so I will just go through some basics in OCT. It is just like ultrasound in the sense instead of sound waves, the light waves are coming, and it is getting reflected from different tissues in the body, and it gets detected by the transducer and displayed. So what is it? It is based on the principle of Michelson interferometry. So that is the principle behind this for postgraduates. And in fact, this all started in the mid-90s when MIT developed the primitive OCT and was given to Carl Zeiss for marketing. It was called OCT 1000, and then the time domain, spectral domain, and set source OCT came. Everyone should understand little difference between time domain and spectral domain OCT. The time domain OCT was called Stratus. The other one is Cirrus by Carl Zeiss. Different companies have different names. Spectralis, like that. And the A scan speed is much more in spectral domain, and B scan also is very sensitive in spectral domain. all this has resulted in improvement in axial resolution and the clarity and the less the aberrations and everything is there in the spectral domain. So we have done away with the time domain when we are using spectral domain mostly now. It is called optical biopsy because all the layers seen under the microscope is seen in the OCT. So this is one basic picture. I am using all grayscale picture, not green and red, which is seen in some printouts. Grayscale will give you more details on the structure. In the OCT, if you see the nerve fiber layer, this is thicker on this side. So this is the nasal side usually, and this is the temporal side. And some dots you can see inside. These are all blood vessels. Just we start from there. And how to interpret, I will go into the details. There are some important landmarks in the OCT, which always you should look. One is the external limiting membrane, then the ellipsoid line, initially called the ISOS junction, then the retinal pigment epithelium Bruch's complex. And these are some of the important layers that we look at when you do the OCT. So this is ellipsoid junction. The ELM is very clearly seen, ellipsoid junction, then the RP Bruch's complex. So all the layers in OCT and even now with the advancement of technique, the choroid can be seen. It is called enhanced depth imaging in some machines. So here you can see the small choriocapillaries, medium vessel, large vessel. All the choroidal vessels are also seen. So this has made tremendous changes in the pathology, in the defining pathology of different diseases. So there are some rules. Never interpret OCT with one printout, just like ultrasound B scan, never interpret in one printout. Multiple sections are needed, and you just make sure that you are watching actually looking at the right plane. So evaluating the OCT images, the first you have to see the scan quality, and then overall scan profile, and then foveal profile. I will just show some examples and run through this. This is scan quality is much better in the upper one compared to the lower one. And overall scan profile, like this is an edema, like the retina is bulging. So overall scan profile, the convexity you can make out. Then go to the foveal profile, foveal contour can be made out. This is a perfect scan with all the layers and good normal retina. Now, don't forget to see the scan plane. Like there's a BRVO, in the upper scan you can see it is through the hemorrhages, while in the lower part it is normal. The retina thickness is normal. So if you see only the lower picture, you may think that it is normal. So systematic approach is always needed, especially for postgraduates. Identify the retinal pigment epithelium, examine the retinal pigment epithelium, then posterior to RP and anterior to RP. If you go like that, you will never miss anything. Like this, the retinal pigment epithelium is here. It is regular and slightly raised, a small PED is there. And then if you go behind the retinal pigment epithelium, there is a PED, which clear area, with the hyperreflective area inside, there is no interruption. And then you go anterior to there are a lot of findings here, like hyperreflective edema, hyperreflective dots, cystoid changes, all these are there when you see anterior. So like that, if you systematically go, you will not miss anything. I will show some common cases for students. First of all, I will start with the vitreomacular interface diseases. This, as you know, this is the posterior hyaloid. Vitreous is getting attached here. We call it vitreomacular adhesion because the foveal contour is not lost. It is not distorted. So it is a vitreomacular adhesion and there is no distortion. So it is a focal vitreomacular adhesion. But when it pulls more, the distortion of foveal contour occurs and it is called vitreomacular traction. So this is a VMT, which is a focal VMT. If it is a large VMT, the diffuse, it is called diffuse VMT. Once it progresses into a full thickness macular hole, it is an anatomical defect with complete interruption here. And now the classification of IVTS, the classification is quite simple. This is based on the size of the hole. It can be small, less than 250, medium or large. And you can just tell whether there is VMT or not. Here, there are VMT. It is with or without VMT. These are some examples. This is a primary medium-sized macular hole with VMT. Now coming to lamellar macular hole, this can be of two types. As I explained, partial thickness. it is there is no loss of tissue below the on the base of the hole, and there are two types. It is called tractional or degenerative. In tractional, usually there will be an epiretinal membrane like this, and this is a partial hole, and here the tissue is preserved. And in degenerative, you don't see an epiretinal membrane. There can be something associated with the thickening of the epiretinal proliferation. That is called lamellar hole associated epiretinal proliferation. So these are the two types of lamellar hole. Now coming to what is this? This is just an epiretinal membrane with multiple attachments. Multiple layers are there, epiretinal membrane. And in doing a scan of ERM cases, you have to see the different planes which is going through the macula. Sometimes the whole retina is distorted, so that you don't know that the prognosis for epiretinal removal membrane ERM removal is not very great. Now coming to DME, there are two types of DME: center sparing and center involving. This is don't look always at the color photo only. Here there is redness here. So, but the fovea is not affected. The main thing is in center sparing DME, we do based on ETDRS classification laser treatment. And in all other cases, we have different types of edema. This is a sponge-like edema or spongiform edema. Most of the eyes have spongiform edema, and this CMT, central macular thickness alone, is not the criteria. Now, this is a cystoid edema where you can see cystoid changes in different layers. It can be small in the inner retina, and later it fuses to form a larger. So this is cystoid edema. And the most important other finding we see in diabetic macular edema is submacular or subfoveal detachment like this. The pearl is that in these cases, the visual recovery may be better than cystoid edema. This once it dissolves, once it absorbs after injection, the visual recovery may be better. So this is another case of DME. This is the angiogram and some taut hyaloid with pulling the macula. These are not ideal cases for injection, but going for surgery. And sometimes you can get hard X-ray at the fovea, which is seen as hyperreflective area here. So these are some of the findings. And to continue on the DME, there is a condition called disorganized retinal inner layers, where all the layers are not at all identifiable. Here, even though this looks better eye, this layer is not identified in this area, while this looks a bad eye in OCT, but all the layers are identifiable. So in fact, this is the bad eye compared to this eye, because drill has a poor visual prognosis. And there is something called pearl necklace sign, where there are a lot of hard X-ray around the cyst or under the serous macular detachment, which can go for precipitation once you start injecting. Coming to OCT in wet AMD, PCV and CSR, I am covering together. There are two types of choroidal neovascular membrane. Type 1, not two types, basically sub-RP and pre-RP. The one that is under the RP is type 1. One in front of the RP is type 2. So these are left one is the old, we used to tell occult CNVM. Now in OCT, we can call it a type 1 and type 2 CNVM. I will come with some pictures. The spectral OCT has different findings which can indicate whether it is an active CNVM or inactive CNVM, and whether it is a chronic disease or a fresh disease. Like these are some of the active signs of activity. If you see this one, there is edema pre-RP complex, while this is a pigment epithelial detachment with intraretinal edema, and here there is a lot of subretinal hemorrhage and hemorrhagic PD. These are all signs of activity, while these are all signs of chronicity, like cystoid area, like outer retinal tubulations, huge cyst, and all these things are signs of chronicity. So I will come to the different types of pigment epithelial detachment, because sometimes you will come across all these printouts, different types of, and the commonest one that we see is in CSR. This is a serous macular detachment, while the small one here is a serous PED, seen mainly in central serous chorioretinopathy. And here the content is very clear, and there is all the choroidal layers are clearly visible, no reduced backscattering. While in hemorrhagic PED, usually huge, the underlying subretinal area or the choroidal area may not be clearly seen in hemorrhagic PED. Fibrovascular PED is the third one, where it is not that big, but there are hyperreflective area inside the PED, and you can make out the choroidal layer. So this is a fibrovascular PED. And depending on the shape of the PED, you can have dome shaped, irregular or notched PEDs, All these are important because some of the notched PED can have underlying polyp lesion. Tall peaked and thumb-like PEDs are other type. Thumb-like PED is due to the shape. Here there are some hyperreflective area, and usually this contains a polyp. So these are all indicative of PCV. This is another thumb-like PED, and what you see is separation of the Brux RPE. It is called double layer side, which is also seen in PCV. Extra large PED, huge PEDs are usually part of PCV. Then coming to the type 3 CNVM or RAP, we see trapezoid PED, more intraretinal changes and clinically hemorrhages will be there. So this is another type seen in retinal angiomatous proliferance. And if you see the other eye, many of them will have what is called reticular pseudodrusen, which are pre-RP small drusen-like lesion, unlike a ordinary drusen, which is sub-RP. Now, with enhanced depth imaging, we can see more choroid. If you see the picture above and see the picture below, the lower one shows more choroid, details of choroid. So it is called enhanced depth imaging. And with identification of choroidal features, we can divide it into pachychoroid disease. There is a group of disease starting from pachychoroid pigment epitheliopathy, central serous retinopathy to pachychoroid neovasculopathy and PCV. This is a spectrum of diseases. And the serous macular detachment can be followed up. If you follow up CSR, the variation in the choroidal thickness can be found. Now in OCT, in other diseases, mainly I have covered only 2-3 topics. Inflammatory diseases in Haradas and all, you can see this sort of irregular mounds of choroid with large serous detachment and many septae, and this sort of picture is usually seen in Haradas disease and inflammatory conditions. And central retinal vein is a very common, or BRV also, very common disease where you can get a diffuse mixture of spongiform and cystoid change. And sometimes if there is a combination of arterial occlusion, you can see some whitening of the inner retina also. And central retinal artery occlusion, as you can see the whitening in the color photo, there will be inner retinal whitening. These are some of the findings of other diseases. And so based on all these things, I can just tell that don't interpret based on one printout. And every OCT is not for injection. Don't miss subtle findings, and central macular thickness is not everything. So these are some of the things that I conclude. And coming to OCTA, Gopal has told me to cover OCTA also. OCTA is a non-invasive new imaging technique that employs motion contrast imaging or high resolution blood flow. Basically, the blood flow, the RBCs keep on moving. So when you take multiple B scans and continuously present it, it will look as if the vessels are completely seen. So this is the principle of optical coherence tomography angiography. Repeated B scan of each location, and then continuous decorrelation analysis will show the blood vessels as seen in this picture, picture D. So that is a basic principle. And you can see the superficial retinal layers, blood vessels, middle layer, lower layer, and the avascular layer, then choriocapillaries, avascular and choriocapillaries and optic. All these vessels can be seen. The current disadvantage of OCTA is we are not able to visualize the peripheral choroidal, peripheral vessels with OCTA with the techniques now. Now current users, I will just go through, rush through some of the users. Suppose the patient has renal problem and you don't know what is the cause for defective vision. Here it is only 3 meter vision in the left eye. What is the cause of defective vision? And you can't do an angiogram, proper fluorescent angiogram. You can rely on OCTA. Beautifully, you can see the ischemic maculopathy in these cases. And the second the use that we have found is in what is called pachychoroid neovasculopathy. As I have told, there's a spectrum of diseases, and in these cases where there is no actual polyp in ICG, but you can see some PCN-like lesion, neovascular lesion in OCTA. Here there is, it looks like a CSR lesion, and there is some pachy vessels here in OCT. But when you do OCTA, you can see some network in the avascular region suggestive of neovascular element. So you can detect all these things at an earlier stage and easy to interpret compared to some angiography. The third one that I have found useful is in myopic CNVM. As you know that the edema and intraretinal changes are much less, and still the standard of care, the investigation of choice is fluorescent angiogram. But in OCTA, you can see the network nicely in many of these cases. So you can avoid angiography. Then there is a new term called non-exudative choroidal neovascular membrane, especially in the other eye of patients. Here, this patient's left eye has already on treatment with injections and all. The right eye looks quite okay. But if you see the OCT is absolutely normal. The OCTA shows a silent network. These patients are likely to go into choroidal neovascular membrane in the future. So this is a prognostic importance. Just to some points to highlight, there are different patterns of choroidal neovascular membrane. Medusa head, where it is looking like a Medusa head, and the in Octa the halo around is supposed to be a sign of activity, and this thin tiny capillaries and anastomosis are signs of activity. So this is Medusa head. Then the next one is called the C-fan pattern, where there is a eccentric feeder vessel and the vessels with the anastomosis and the halo. These two are active choroidal neovascular membrane seen in Octa. And there is an indistinct pattern with thin branches, no detectable feeder vessel, and a prune tree vascular pattern, that is mature vessels, which may not, these sort of cases, they may not respond to our anti-VEGF injections. So these are some of the uses of Octa and types of Octa. If you ask, you are asked about a short note for Octa, you can write all this. And another very useful thing is detection of polyps in this. The left one is an ICG and right one is an Octa, and you can see almost it replicates ICG in detecting polyps in many of these cases. Octa does not show leakage. That is the major problem. If you see the Octa of the optic disc, doesn't look anything abnormal, but the angiogram shows leakage. That is one major disadvantage currently. And if the flow in the polyp or vessels is less, it may not be seen in Octa. So here, angiogram, you can see a aneurysm polyp. Here you can't see anything. So if the flow is less, you can't see. And some artifacts are still there.
I think we can conclude, no?
Yeah. Over.
We have significantly
Yeah. But the two topics together is very difficult in 10 minutes. Motion artifact and some projection artifacts, these are all problems. And that's it. Thank you. Gopal, 10 seconds extra. Sorry.
Thank you, Dr. Mahesh, for that wonderful presentation. You tried to cover the maximum possible in that time. Let's move on to the next topic. We have Dr. Srinivas Joshi from M.M. Joshi Hospital, Hubli. He'll be talking to us on the angiograms, the FFA and ICG angiograms, and autofluorescence. Dr. Srinivas. Dr. Srinivas, I think your audio is off.
Yeah, you're able to see my screen, sir, now?
Yeah. Yes, go ahead, please.
Okay. Good evening, everyone. First of all, I would like to thank the entire Cochin Ophthalmic Club and Sai sir and particularly Gopal Pillai sir for having in this interesting meeting. Thank you very much for this opportunity, sir. So I'll be quickly covering on the FFA, ICG and the FAF. So coming to for the interest of the postgraduates, so what is important to know whenever you are having a case with FFA, whenever it's given as a chart, it's also important to know first what are the clinical findings in that patient, then red-free image and whether the pseudo or the autofluorescence image, which eye we have to describe it, and is there any arm retina delay. Then you have to look in for the sequential, that is the phase by phase. Then go in for anatomical, whether it is at the choroidal, subretinal or at the neurosensory. And then last one is to comment is whether it's a hyperfluorescence or the hypofluorescence. So it would be nice if you can go through the systematic order, that is scan through the macula first and then go into the major vascular arcade, then the disc, periphery, and then look for any pathognomic features in the periphery. So if we ask which phase is this, definitely you can see there is a choroidal fluorescence here. The arteries and the veins are still not filled at all. There is no dye at all, but definitely you can see one small artery filling it up here. This is the choroidal phase and the cilioretinal artery which fills up in the choroidal phase. So coming to a little bit about the causes of the hyperfluorescence, as we all know, it might be due to the window defect and or it can be due to the pooling of the dye. In the pooling of the dye, you have two sorts. One is under the RP, like a pigment epithelial detachment. The simple example is like a rheostat of your slit lamp. That means when you turn it, only the intensity increases, whereas the size remains the same, which is very peculiar of PEDs. Whereas in case of central serous retinopathy, you see the leakage under the neurosensory retina, which is CSR pattern. Then you have the causes like leakage, whether it's into the cystoid macular edema or whether it is from the new vessels, which call it as the neovascularization associated with drusen, which is for the staining. So what are the causes for the hypofluorescence? It can be either due to blocked retina or choroidal fluorescence, like sometimes the blood abnormal material, increased pigmentation, whether it can be a pre-retinal, intraretinal blood. So coming to quickly to the cases. So let's go into a few of the cases examples, which I think will be more interesting rather than making a theoretical slides. So here you can see all the three phases of the angiogram are there. In the late phase, definitely you can see there is the leakage that is in the form of flower petal pattern that is in the late phases. And the OCT is also showing intraretinal cystoid spaces, which is very classical of CME due to Irwin gas syndrome. Now you have another picture here. You can see the FA at the 2 minute and then FA at 10 minutes. Definitely you can see a small amount of hyperfluorescence, which is increasing in size in the late phases, which is very typical as the ink blot pattern in case of CSCR. This is another example case where you can see in the late phase, you can see definitely the blot pattern of CSCR. Now coming to the next, again, whenever any case is given, first, as I said, which eye, then you have to tell which phase is the angiogram, whether it's arterial phase, early venous phase, mid venous phase, late phase, or elimination phase. So now you can see here is the late phase is because you can see the arteries are already fading out and the veins still some amount of dye is still there. So it's a late venous phase when definitely you can see there is a smokestack pattern of the leakage into the neurosensory retina, which can also be called as an umbrella pattern, or some call it as a mushroom pattern. So this is the subsets of CSCR. Now coming to the next is the DR, diabetic retinopathy. Here you can see again the arteries are already filled up, the veins are already filled up, but definitely you can see small amount of hyperfluorescent area, very dot hyperfluorescent area, which is just increasing in the late frames, which is nothing but the microaneurysms. But definitely in these areas you can see the hyperfluorescence is slowly increasing in its intensity. And this is the other eye where you can see, again, you can see the hyperfluorescence here above the arcade. And in the late phase, definitely you can see there is increased hyperfluorescence. That is because of the leakage due to NVE. This is the case of PDR. So here you can see the differences between NVD. So in NVD, definitely you can have a leakage. In the late phase of the angiogram, you can see the CNP areas here, and you can see some amount of microaneurysms here. And this is again NVE, which is showing leakage in the angiogram. Now coming to the same with the collateral. So how do you differentiate? You can see here the NVEs usually leak, whereas collateral do not leak here. You can see on the disc there are the collateral vessels, which doesn't show any leakage. So that answer is the differentiating point. So coming to the CNVM, on the FFA and ICG, it can be classified as a predominantly classic, minimally classic, and occult CNVM. So here, as I said, if you ask your examiner for the sequential phases of the angiogram would be better, because usually the lacy pattern, what we see here is in the early frames of the angiogram. So if we miss the early frames, then the lacy pattern might be missed. So this is a very classic case of classic CNVM. So again, you have the second variant is the minimally classic CNVM, and then you have what is called as the occult CNVM. Here you can see in the late phase of the angiogram of the right eye, where you can see there is no much amount of dye either in the arteries or the veins. This is definitely a late phase. You can see the drusen here. You can definitely see some amount of leakage here. And this is the ICG, which shows a plaque. And this is a very nice picture to differentiate between angiography and ICG. For the interest of the postgraduates here, if you see the fluorescein angiography, they usually have the vessels are the, you can see the retinal vessels, they're nicely highlighted. And the choroidal vessels you do not see in FA, whereas in these ICG, you can definitely see the choroidal vessels very nice here. And usually if there is no pathology, then the disc usually will be jet black. Now coming to the feature here, you can just see some amount of hyperfluorescence here, you can call it a stippled hyperfluorescence, but definitely you're not able to see what is the exact pathology. The same, if you see through the ICG here, you can see a nice vascular pattern which is showing up here underneath the blood here. You can see this is the hypofluorescence because of the blocked fluorescence. So this is the differentiating features between an FA and ICG. ICG scores better in case of identifying occult CNVMs and also in cases of PCV. Now you can, how do you classify this occult CNVM? Now you can see this is again the late phase. You can see there is a stippled hyperfluorescence here. Again, you can see the leakage in the late phase. This is the OCT picture. If they give you the OCT picture, then it definitely helps you aid in diagnosis. So you call it as type 1. We call it as a fibrovascular PED, that is irregular elevation of the RPs, stippled hyperfluorescence seen by 2 minutes and persistent staining or leaking into the neurosensory by the late frames. Now, coming to the second variant is called as the late leakage of undetermined source, that is LLUS. You can see the early frames here and you can see the late frames here. You're not able to make out where is the exact source of the leakage of the hyperfluorescence with the pooling of the dye into the sensory subretinal space at 2 to 5 minutes in absence of the visualized source is nothing but called as the late leakage of unknown origin. Now, how do you classify it anatomically? It is called as extrafoveal if it is more than 200 microns from the center of the fovea, and you call it as subfoveal if it is underneath, and you can call it as juxtafoveal if it is within 200 microns to the center of the FAZ. So we call it as a juxtafoveal. So coming to the next is, you can see here, this is again a favorite question of the examiners. How do you differentiate? This is definitely an ICG, left eye. You can see the dye is already filled up here, and because of the jet black appearance of the disc here. But here you can see this is the hot spot and this is the plaque. So what's the difference? If it is less than 1 disc diameter, it is called as the hot spot. If it is more than 1 disc diameter, it is called as the plaque. I'll just switch off the timing. It is, this is causing it to move to the next frames quickly. Okay, sorry for that. Okay, so coming to the next, after the hotspot and the plaque, and again you can see here this is again a classic example between the FA versus ICG. Here you can see the retinal vessels very nicely seen. So this is a case of FA, whereas in ICG you can see the choroidal vessels better here, and again on the disc it appears hypocynoscent, and here it's not hypoid. So if you see the lesion here, this is, you can see the leakage happening. This is because of the PED, whereas the same one in ICG, it shows hypocynoscence. And definitely you can see some nodular hyperfluorescent things are seen here, which is nothing but the polyp. So this is the case of PCV when you differentiate between FA and the ICG. And in the ICG, you can definitely see the nodular hyperfluorescence in 90% of the cases. You see the branching vascular network of the inner choroidals in 75% of the case of PCV, and hyperfluorescent halo in the first 6 minutes in 50% of the cases. So if you can see this pulsating polyp, if you can appreciate here, in the case of dynamic ICG, you can see the pulsating polyps as well. Now, coming to the next variant, you can definitely have a look. There's a large PED here, which Dr. Mahesh very nicely covered. And definitely you can see some intraretinal fluid spaces on the OCT. Now, what is this? Now, let's go into the angiogram of the left eye. Definitely, you can see some amount of hyperfluorescence here, which is not very clear. But same, if you look at the ICG, definitely this is the PED, which is causing hypocynoscence, and some amount of hyperfluorescence is seen. So let us zoom it. Definitely you can see the retinal vessels going inside the substance of this lesion. So probably it's a retinal anastomosis. Sorry, I can't see the retinochoroidal. I cannot show it in this picture here. But this is definitely a case of RAP, where you have the retinal anastomosis. And in stage 3 RAP, you have retinochoroidal anastomosis. And this is a very new terminology, is RP aperture, where you have a gap in the RP where the intraretinal CNVM that tries to go deeper and deeper into the subretinal and then into the choroid if the section is taken at that. So that's the RP aperture. Now moving quickly to the next set, you can see here, this is the IR image. This is the autofluorescence. You can see the hypoautofluorescence here, some hyper here, and then you can see the clinical picture. Now, this is the very typical case of RP tear. So what happens here, the RP gets torn here and it gets rolled up. So because of this, you get a hypofluorescence here because of the blocked fluorescence. And this is the window defect. Because there is no RP, you can see the choroidal fluorescence very well. The choriocapillaries very well. And in the ICG, definitely you can see these choroidal vessels very well delineated. So this is nothing but the case of RP rip. And definitely the OCT, you can see here, there is discontinuity of the RP in this area, which shows the rip. Now coming to the next is FAF, that is the metabolic mapping of the RP, developed as a tool to evaluate the RP during aging and the ocular disease here. So normal FAF, ONH usually causes absence of AF pigments. The blood vessels shows hypoautofluorescence because of the absorption by the blood vessels. Fovea also shows hypoautofluorescence because of the luteal pigments. And the excessive accumulation of lipofuscin in the lysosomal compartment of the RP is the downstream of many hereditary and the age-related disease. So it helps in picking up the disease. So if you can see the FAF in ARMD, as you all know, the hallmark of aging is lipofuscin granules in the RP cytoplasm. You can see hypoautofluorescent areas here, whereas at the border, you can definitely see the hyperautofluorescent area, which shows the sign of previous or future oxidative injury. Then coming to the advanced ARMD, many areas of hypoautofluorescence, you can see here, large areas of hypoautofluorescence, no RPE, no lipofuscins, that's why no autofluorescence there. And it's also important, the AF is important in monitoring the progression of the disease and definitely how it marches to the later end. Then Stargardts, you can see here, there's a large area of RP atrophy here because of the Stargardts, and the flex, definitely you can see as the depigmented lesion, that is again hypo-AF. Now I'll just skip this in the case of retinitis. I'll just move to the last two slides. And now you can see the serpiginous choroidopathy here. The patient presented at this stage, it was silent. Now you can see along with the scar of this, you can see some amount areas of hyperautofluorescence has already started. And definitely now you can see there is increased hyperfluorescence at the edge of these hypoautofluorescent scars, and there is some amount of vitritis because of which you are having a slightly poor focus. So this patient was started on steroids and he was doing. So my intention to show this is it also helps in showing the progression of the disease and how to prognosticate and also the treatment aspect. So this is another case of multifocal choroiditis, my last slide. You can see there's a dark scars here. And again, if you see here, it gets activated. So once it gets activated, it becomes hyperautofluorescent. And definitely this is the stage where we need to treat these patients. And we started him on steroids and the patient is doing well. So in case of chronic CSC, you can see the tract here of this in the autofluorescence. So basically FFA ICG helps in hemodynamics and the fluid dynamics. OCT helps to know about the size and the elevation of the detachment, whereas the autofluorescence always helps to know the functional status of the RPE. So with this, I would like to conclude my talk. Thank you very much. I would like to thank my fellow Dr. Giriraj for pulling up these cases from the OCT pictures and the FA. Thank you very much.
Thank you, Dr. Srinivas, for that wonderful talk again. I think you kept up the time also. Thank you. So let's call upon Dr. Neha Goel. She's going to speak on a very difficult topic to cover in 10 minutes on electrodiagnostic tests. Dr. Neha.
Thank you so much, Dr. Manoj. At the outset, I'd like to thank the Cochin Ophthalmic Club for this ophthalmic extravaganza, and especially Dr. Sai Kumar and Dr. Gopal for giving me this opportunity. So as rightly said, this is probably the most difficult of the investigations and probably the least used and the least understood, I would say. But even in this era of such advanced ocular imaging, I would still say that electrodiagnostic tests have a very special place. Why special? Because apart from just diagnosis and monitoring, they are the only tests which allow a virtual dissection of the visual system. It's the only functional test, you know. All the ones we've looked at till now are largely anatomical. They don't tell us whether the tissue is living or is dead. And at the same time, it gives us valuable objective information, as in requires minimal patient cooperation to pick up malingerers and the sorts. But it's important to remember that unlike the other tests where you can have a printout of the OCT and the FFA and ask the diagnosis, electrodiagnostic tests are not like that. You can have the same result in a variety of clinical conditions, and therefore a clinical evaluation is very important even before you order a test to understand which one to order and how to interpret the result. So in that way, it is different. You cannot give a printout to somebody and kind of make them guess the diagnosis because it varies according to the clinical picture. Now, I'll run my talk through these basic subheadings. We look at the basics of the test, the recording, what normal looks like, that's very important. And then I'll just share 5 clinical case scenarios where electrodiagnostic tests are and should be incorporated. Now, the ICER standard clinical tests include the flash or full field ERG, the pattern ERG, the electrooculogram, and a flash and pattern VP. The multifocal ERG is not a part of the standard tests. Now, these tests basically utilize the primarily vertical pathway of neural visual information flow, where, as we know, visual information flows in a particular direction. And the different tests pick up abnormalities in the different structures, which can be affected in these various diseases. So it's actually quite mathematical if you oversimplify it. Now, this is an important slide. This is actually a summary slide. And I'm sorry, this tells us that the origin of the signals is basically determined by the visual stimulus characteristics, the electrode placement, and the state of dark or light adaptation. So these are the things which are different in these tests, and which is why we get different waveforms. I've also written the time taken for these tests on the left-hand side. And as we can see, the full field ERG takes the longest because of the dark and light adaptation. It's also important to know for which test you need to be dilated and for which test you need to have the refractive correction in place, which your technician or optometrist will be well versed with. Now, the ICEP, the International Society for Clinical Electrophysiology of Vision, is the one which sets out the standards for these. Now, this is to encourage uniformity because every lab will have its different values for normal, and it also encourages that you should have your own normative database. So if you recently procure a machine, you should do some hundreds of patients which are normal just to know what your normal looks like. Now, these are some of the basics about recording. A minimum of 3 electrodes are needed. I'll just show you. Now, millivolts you get in EOG, the results that you get. Whereas an ERG, it's in some place of the 100 microvolt. That is what the results are in. And VP is in maybe tens of microvolts. So these are the electrodes commonly used. The ones in practice are DTL, which is the most commonly used, and gold foil, which is also good but a bit expensive because they are disposable. So these also allow clear pattern stimulation, as we'll just see. So 3 electrodes. One is the active, which is placed here, the inactive, which is placed at the outer canthus, and a ground electrode, which is at the forehead. This is for all the ERG recordings. For the VP, the electrodes are reusable. You just need a single set. They are the same as those used for EEG. So it's really quite cost effective in that manner. And these are how the electrodes are placed. Now, these go into a preamplifier and then the amplifier, which will magnify the signals. And you have filters to get out a perfect waveform and averaging to decrease the noise. So let's look at the stimuli. This is the Gansfield bowl at the top. And these Gansfield flashes are used for the flash ERG and the flash VP. So some basic principles here: whenever you use a flash stimulus, the pupil should be dilated so that maximum amount of light can enter the eye. First. Secondly, these tests can be done in poor vision also, or in uncooperative patients also. Now, these 2 points are different in the pattern stimuli. Now, pattern can be pattern ERG or pattern VP. Here, you need the patient to look at the pattern. So, if you have a malingerer or an uncooperative patient, you will not get a proper result. The patient has to look at the pattern and focus on it, and therefore, you need natural pupils and refracted. It's very easy to remember like that. And multifocal ERG, multifocal VP is still very less used, have this kind of flickering pattern that is also a kind of a pattern stimulus only. Now, another concept is how much of the retina is stimulated, and that is important in interpreting the result. So for the EOG or the full field ERG, it's the entire central and the peripheral retina. So if there is a small central lesion, that test will not come up to be abnormal. That's important to remember. If you are looking at an abnormality in the central retina, then it's better to order a pattern ERG or a multifocal ERG. These are the ones which focus on the macula. And while we conventionally know that a pattern VEP is for optic nerve disorders, don't forget that it has a large contribution from the macula. So sometimes macular pathologies will also give rise to pattern VEP delays. The results are displayed as graphs, as we know, and again for analysis there are some basic concepts. If the amplitude is decreased, it means there is more of cell death, whereas if the implicit time or the latency is increased, it means there are more number of dysfunctional cells which are still not dead, and you have to compare with your own normative database. Now next, let's look at what the normal looks like. This is a normal flash ERG. So basically we look at 5 responses. These are according to the ICEF. First is the rod response. Second is the combined rod and cone response, which can be both 3.0 and 10.0 when the stimulus is a bit stronger. Fourth is the scotopic oscillatory potentials. Fifth is the single flash cone response. And finally, fifth is the 30 Hertz flicker. So without these 5, a full field ERG is not complete, and each of them I've written what are the origins of the cells, and accordingly we see where the abnormality lies. So flash ERG is a masked response and it separates the rod and the cone response. Pattern ERG, on the other hand, comes from the macula, as we said, and basically here we look at the P50 and the N95. P is for photoreceptors. It is driven by the cone photoreceptors and bipolars. N is for the optic nerve. It is driven by the ganglion cells and the optic nerve. Multifocal ERG is still quite specialized testing, and it will give you multiple areas on the macula. So it has an advantage of topographic localization. Pattern VEP is the most commonly done for the pathway, for the pre-chiasmatic optic nerve pathway, and we usually look at the P100 part of the wave here. And then finally the flash VEP, which again we look at the P2, which is the most important, which should come somewhere around 100 milliseconds. Finally, the EOG, where we look at the Arden ratio, around about 1.8 or above is considered normal here. So now that we know about the test, let's come to the final part, which is the clinical interpretation and their use in clinical practice. So for simplification, I divide it into 5 clinical case scenarios, which we encounter very commonly in our OPDs and clinics. And these are the ones where we should utilize electrodiagnostic tests, both for diagnosis and for monitoring. First is nyctalopia, whenever a patient of night blindness comes to you. Of course, retinitis pigmentosa in such cases is a clear-cut diagnosis, and you don't need a full field ERG for that. All you will get is an extinguished response. But there is utilization of electrodiagnostic tests to assess the residual cone function. As we can see here, multifocal ERG will show you this small foveal peak, which corroborates with the remaining subfoveal photoreceptors. Similarly, ERG is important when you are not sure of the diagnosis and also in carrier detection. So when the patient comes with his or her relatives or children, you can advise in them. Then another patient of night blindness where you see the fundus is normal, the OCT is normal, the vision is normal, and you don't know what the diagnosis is. We order the ERG, and here we see in the combined rod cone response what is called a negative ERG. So this is what is a classic negative ERG. The normal amplitude A wave is larger than the B wave. It looks like a negative ERG. Remaining is normal. So this is a patient of what we call CSNB or congenital stationary night blindness. It's important to recognize because as the name suggests, it's stationary. You don't need any further testing. You just need to reassure the patient. Sometimes you have this with abnormal fundi like this, and sometimes you have it with a completely normal fundus like I showed. The third situation, again, normal fundus, normal OCT 6.6, decreased vision at night. So here we see there is somewhat a negative ERG, but more importantly, if you see the pattern ERG and the multifocal ERG is also decreased. So this gives a hint that this is a case of vitamin A deficiency, and actually retrospectively on history taking, you reach the diagnosis. This is important because as we know, it is easily treatable. So to distinguish these conditions, you need a ERG. Remember, ERG is the only one which isolates the rods, and also remember that if it's a macular pathology, the ERG will be normal. Now, second, coming to what we call the dustbin diagnosis or the heretomacular degenerations. So this was a child with decreased vision. As you can see from the fundus photo, he was very photophobic even to the flash, and he had subfoveal photoreceptor defects. So the clinical picture does point to the diagnosis, but the ERG clinches it. There's absolutely no cone response, and this was a case of achromatopsia. Color vision was also affected. Again, it's important for counseling of the further generations, and we can offer them red tinted glasses. They do help, as Dr. Jalali says. Now, cone dystrophy is surprisingly common, and especially the progressive one, but we don't normally see the bullseye maculopathy that often. So just to summarize, these are the clinical applications of ERG to separate the rods and cones. Negative ERG, which has a list of inherited and acquired causes. Extinguished ERG, which you will find only in about a handful of conditions. So if you get that, your diagnosis is pretty much clear. Now, another of the heretomacular degeneration is something which looks like this: altered foveal reflex, scarring on the OCT. You order a full field ERG and it's normal. So is it not an HMD? No, it still is. You must get a pattern ERG done. And here you see it's quite flat. So this suggests that it is a macular dystrophy or Stargardt's disease. Now, again, sometimes you have the pathognomonic pictures like this where you don't need ERG for the diagnosis. So what is the use? ERG does help in prognostication of these cases, so should still be done. And finally, we have this, most commonly we encounter this classic appearance where there's a subfoveal vitelliform lesion and a typical fundus picture. And here we see that the EOG is decreased. So here I would like to say, for the diagnosis of Best disease, EOG has more of a negative predictive value in atypical cases. Now, thirdly, coming to unexplained visual loss. Now, usually when we encounter this, instead of ordering all the tests like OCT, visual fields, and angiography, we can do a simple pattern ERG, and that will tell us whether it is a macular pathology or an optic nerve pathology, and then we can tailor our further course accordingly. Now, if it's a macular pathology, as I said, you remember photoreceptor P, so the P50 will be affected, whereas if it's an optic nerve pathology, N95 will be selectively reduced. This is a very useful flowchart by Professor Graham Holder, which will kind of oversimplify the path you should take in a case of unexplained visual loss. And fourth, coming to toxic retinopathy. Now, hydroxychloroquine, which is suddenly a very much talked about drug, but for years, patients of rheumatoid arthritis and SLE have been taking it chronically, and they do come for monitoring their toxicity. So actually, a couple of screening tests are recommended, in which we have visual fields, SDOCT, autofluorescence, and multifocal ERG is also part of that. So usually when we have abnormalities on 2 or more tests on 2 or more occasions, only then we order stoppage of the drug, because it is actually a life-saving drug for these patients. And there's a typical pattern of toxicity that we see. So multifocal ERG, remember, I see a lot of retina specialists, myself included, pre this, where, when we don't know the diagnosis, we order a multifocal ERG and then we say it hasn't told us anything. It will not tell you anything. Multifocal ERG will just give you topographic localization of the abnormal areas at the macula. If you don't know what the patient has, you have to order a pattern ERG, as we have just learned. And in the toxic retinopathies, of course, we have sidrosis, where we must order a ERG before we operate a patient of a foreign body for prognosis. Finally, coming to optic nerve disorders. So in this, I'll just like to mention the caveats of VEP again, because what we often do is order a VEP and then say it's not telling us anything. So basically, VEP will only tell you if there is a pre-chiasmatic optic neuropathy. So if there is a post-chiasmatic optic neuropathy, it will be normal. That's important to remember. Your patient might still not be seeing, but it will be normal. Secondly, it is very much dominated by the central visual field. So if you have a patch of geographic atrophy sitting there, your pattern VEP will be depressed. That doesn't mean that the patient has an optic nerve pathology. So these are the 2 points which are important to remember while ordering and while interpreting. Whenever possible, order a pattern test over a flash test, unless you have a uncooperative patient, a child, or a malingerer. So in optic neuritis, very often the question is asked, should VEP be ordered? You know the diagnosis, you can see it on the fields, even on the nerve sometimes. Yes, it should be ordered. Why? To diagnose subclinical optic nerve involvement in the other eye. Like in this case, you see Clinically, only the left eye seems to be affected, but when you do the patent VP, there's a delay in the right eye as well. So this is the subclinical optic nerve involvement, very common in MS as well. Also, during recovery, even though the vision might come to normal, the fields might come to normal, the patent VP takes some time to come to normal. Here again, we can see. And so it's important to monitor and follow up the patients with this as well. So in any kind of optic neuropathy, whether it's toxic or traumatic or related to an infarct, VP is important for diagnosis. Again, I repeat, pre-chiasmatic diseases only, and also for monitoring. Like many times you have patients of CNS tumors who are operated. So visual fields are not enough. VP is definitely more sensitive to do pre-operatively and regularly post-operatively as well, because many times neurosurgeons send these patients to us for ophthalmic evaluation. Similarly, patients on ethambutol who are very often sent to us, a patent VEP would be the most sensitive test to follow them up. And of course, in children, when you get patients of delayed visual maturation or cortical visual impairment, flash VP is again important. So just to summarize and finish, these are the 5 clinical scenarios where electrodiagnostic tests really help us. But again, they should be placed in the proper clinical context, and you should use other imaging modalities as well. Thank you. I hope I've been able to simplify this topic a bit, and I'm open to any questions.
Thank you, Dr. Neha. That was a wonderful talk, because you made this difficult topic quite simple to, at least for the postgraduates. Thank you once again for that wonderful talk. Now I think now that we have had 3 diagnostics that are covered, let's have a bit of discussion. I would like to hand over to Dr. Lalit Verma for a 5-minute discussion.
Thank you, Manoj. In fact, I was sitting here and thinking that our role is redundant. So I was wanting some discussion, because it was one way, and Gopal actually has punished everybody by restricting talks to 10 minutes. It's so difficult. I was saying Srinivas as well as rushing through the slides so fast that it was very difficult to gauge them also. I know it's a difficult job to summarize in 10 minutes about everything about FA, OCT, and what Neha has said about electrodiagnosis. So what I would like to tell for everybody is that never in isolation, all these imaging modalities, nobody should jump to conclusion on a single OCT, or I think Mahesh said very nicely. So always have a clinical picture in front of you, color photograph, the visual acuity data, as well as OCT frames, and very important about the FA and ICG frames. Never comment on one single diagnosis. Don't behave like a consultant that you see leak plus, that does not, is important. So have frames of angiography, frames of OCT, and also OCT. Never comment on one single line or raster or this. So ideally, you should be doing it yourself. If not, have multiple frames. So it is all this multimodal imaging. All this data has to be collated, then only jump to or consider some diagnosis or what. So I can have some comments from Giri as well as Meena about the 3 presentations which have been done till now. Giri first, and maybe Meena.
Yeah, thank you, Lalit. Thanks a lot. Very nice presentations, and as Lalit said, it's not easy to cover everything. I thought I'll just say a few words. One is that I think for a general ophthalmologist in a clinic, when do you advise OCT in a patient? That's very important. In a patient with unexplained visual loss, I think OCT is a very useful non-invasive technique. And in patients with preoperatively, in cataract patients, I think patients who have diabetes, myopia, and again, when you have a situation where the cataract is the cataract cannot explain the visual loss. Visual loss is out of proportion to the quantum of cataract. I think these are situations where an OCT is very useful. Second is in fluorescein angiography, apart from what Srinivas said, I think whenever you interpret an angiogram, you must always have the early, mid, and the late phase together. You can't interpret the FFA with one image. See, very often nowadays, in presentation, they just show one image. So it's very difficult to interpret a fluorescein angiogram with one image, and it's very important to understand the fluorescein angiogram that when you show FFA, show all the three phases together. I think as far as ICG is concerned, I think he covered it very well. And as far as ERG is concerned, unfortunately, I mean, Neha is far more knowledgeable than I think any one of us. So that's all. I don't have anything else to say.
Meena, you want to make any comment for the three presentations?
What I can say is that these investigative modalities should not be used in isolation, and it does not do away with the good routine indirect ophthalmoscopy and a biomicroscopic examination of the macula. Everything has to be taken together, and my take-home message for the postgraduate students is that thorough fundus evaluation along with the necessary investigative modalities is necessary for diagnosis and follow-up of these patients.
So may I add one last comment, if you permit, that today, even in cataract surgeries, even though you may be able to see retina grossly on direct, indirect, and 90D, please get an OCT done, because a lot of these patients, around 15% or 10%, will show some findings on OCT, so that you can discuss with the patient and prognosticate and tell him that your OCT is not as normal as it could be. So therefore, I personally think OCT, like Mahesh said, has become a indispensable kind of tool, not only for retinologists, but for all ophthalmologists, and should be, remembered. Very important. I think he told whether the disease is of interface or inner retina or outer retina, if the RP is intact or not, or we have distortion, whatever he has told, I think very, very nicely. So OCT, I think, is a must. And unexplained visual loss, again, OCT and electrophysiology assumes a lot of importance. So with these few words, I think I hand it over to Gopal and Manoj for further deliberations.
Thank you, sir. I think as all the senior faculty have commented on, we should not go by one single modality. That's the basic point that they were trying to raise. And also Dr. Lalit was highlighting the importance of getting an OCT done pre-operatively, which may actually help us identify some surprises. Now let's get on to some clinical conditions. Our first speaker in the next group of talks will be Dr. Anand Rajendran. He is presently the head of the meteorological services at Arvindai Hospital, Chennai, and he is also currently the scientific committee convener on the VRS side. He'll be talking to us on diabetic retinopathy. Dr. Anand.
Yeah, so I'd like to thank the Cochin Ophthalmic Club, Gopal, Dr. Sai, Dr. Rajiv for having me here. So it's my pleasure to talk to you about diabetic retinopathy, which, well, as you know, today we are sitting amidst COVID pandemic, but the diabetic retinopathy epidemic
Anand, it's not very clearly visible. Anand, it is not very clearly audible.
Unfortunately, India has had the dubious distinction of being the diabetes capital of the world. Yes. Okay, actually, I'm having some internet issues right now. Can you just hold a minute?
Maybe you can cut your video feed.
Okay.
That may increase your audio quality.
Okay. It just went off at 7 p.m. exactly. Is it a bit better now?
Yeah, it is a little better. It is a little better.
Okay.
Yeah, please continue.
Okay. So, yeah, so the classic clinical stages of diabetic retinopathy are well known to, I think, most people here, and I won't elaborate on that. In fact, I'll move over to the more atypical or the unusual presentations in a bit. So this atypical behavior is usually because of the inherent variability in diabetic retinopathy, the systemic and ocular diseases that can affect it. So I'll touch upon diabetic papillopathy first. It's been described as a transient bilateral edema in young patients with good visual acuity and minimal diabetic retinopathy changes. It's been described as the extension of the microangiopathy of diabetic retinopathy onto the optic nerve head. Usual differentials that need to be discounted are papilledema, new vessels of disc, and grade 4 hypertensive retinopathy or malignant hypertension. But what really needs to be distinguished is from anterior ischemic optic neuropathy, of which many people think diabetic papillopathy is actually a milder version. In AON, as you know, you have a pallid disc edema, poorer vision, visual field defects associated with afferent pupillary defects. Now, diabetic papillopathy very often, with just control of diabetes itself, can resolve spontaneously. Featureless retina is another rarely seen feature of DR. It is PDR masquerading as a mild NPDR, associate extensive capillary non-perfusion, which with no cotton wool spots, earmarks, blot hemorrhages in the background. Key feature is white thread-like arterioles that you have to look for. On fluorescein angiography, you can see non-perfusion, new vessels. And what might, to the casual observer, be a case of moderate NPDR is actually featureless retina. And if you look carefully, you see those white thread-like arterioles. Another example where, again, a casual observer might, looking only at the posterior pole, will think this is moderate NPDR, is actually peripheral PDR. So you need to look in the periphery too. Vitreopapillary retraction or tractional papillopathy is something rarely seen. As an example of a case where on the first visit, good acuity, you see this pattern of hemorrhages, like striate hemorrhages emanating from the disc, a tangled skein of vessels being pulled from the disc. And the OCT, it shows you that incipient traction of the optic nerve head substance and that elevation of the peripapillary optic nerve head substance. A few weeks later, vision dropped further. You can see that the entire substance of the optic nerve is virtually pulled out, is vitreous traction. And you can see breakthrough hemorrhage. It's not a PDR hemorrhage, it's a breakthrough hemorrhage. And you can see it lining the crenated folds of the funnel vitreous. And with vitrectomy, it resolved very well. Asymmetric diabetic retinopathy can happen very rarely. There's usually ischemia on the side where there's more tractional hemorrhagic complications, and the milder or moderate NPD on the left side is usually associated with mitigating ocular factors like myopia, glaucoma, optic atrophy, etc. Moving to investigations, diabetic retinopathy. I think the previous segment, a lot of speakers said that in great detail. So basically, it suffices to say that OCT is the prime key investigative modality, different morphological varieties, which have been touched earlier. Spongy cystoid with detachment, skytic edema is also seen in severe cases. Intraretinal, more than subretinal fluid, is deleterious. And OCT is really important in monitoring diabetic retinopathy, DME treatment with the sequential anti-VEGF therapy. OCT angiography, again, I touched upon it, is the new kid on the block. It helps us in a non-invasive manner in looking at the new vessels of disc and monitoring the CNP areas. FFA has a diminishing role now. Academy put out certain practice patterns earlier. Where it really is needed is in looking at laser treatment for macular edema, focal treatment in non-fovea involving areas, evaluating unexplained visual loss such as macular ischemia to identify suspect but clinically obscure retinal neovascularization. ICO guidelines also resonated the same thing, and they also clearly said that you don't need FFA to diagnose diabetic retinopathy, PDR, or DME, all of which are essentially clinical findings. Examples of macular ischemia and diabetic retinopathy. So when you see these white sclerosed vessels on the fundus picture, you should know that there could be underlying macular ischemia. This shows that ultra-wide field imaging modalities have come in. Expensive tool, good for using it for targeting, using what is known as targeted retinal photocoagulation of just these ischemic areas. Well, the management of DME has moved from the erstwhile laser photocoagulation in the 80s to intravitreal steroids at the turn of the century, and the current era of intravitreal anti-VEGF agents, essentially bevacizumab Avastin, ranibizumab Lucentis, or aflibercept or Eylea. I'm just going to give you a distillate from the clinical trials quickly. Results showed us that ranibizumab was the first RCT with the anti-VEGF agent, which showed high efficacy unequivocally. DRCR protocol 1 gave us very important teachings. Ranibizumab laser combination was better than laser or IVTA laser arms, and deferring combination laser was better than prompt laser. Quickly, it shows this 2-year equity plot shows that these combinations better than laser only, and better than IVTA prompt laser. And this advantage for deferring the laser was seen at 3 years as well as at 5 years, as well as with the macular edema plot where it was dried up the macula better. Early intense treatment reduces treatment burden later. So very often with macular edema, we are kind of hesitant to be very aggressive. We're not so with macular neovascularization. But with edema, people tend to think that we need not go very hard, but it's not true. As this graph clearly shows us that with 8 to 9 injections the first year, drastically reduces the number of injections you need later on. And up to 40% of patients and more needed no injections in the third year. Higher safety issues were noted for the previous standard IVTA. in terms of elevated intraocular pressure, glaucoma, as well as cataract surgery. More than half the patients need surgery. Rise and Ride was a trial which blew another important myth that it's never too late for anti-VEGF treatment. Again, very often when a patient comes and says, I've had this swelling, reduced vision for a long time, you see this macular edema, you think that's chronic, you think putting in injections won't work. Well, Rise and Ride shows you that the control arm, the no treatment arm, even after 2 years, the moment these patients were given anti-VEGF therapy, ranibizumab, they started improving. And likewise, the macular edema also magically reduced, started drying out once they were fed anti-VEGF therapy. So Restore showed the same thing virtually with laser-only eyes, and adding lasers didn't seem to reduce the re-injection rates, which was thought with its USP. Well, Bold Vista also showed efficacy for bevacizumab and aflibercept, but it was DRCR protocol T which compared all these three and showed two important things: that there was higher efficacy for aflibercept ranibizumab over bevacizumab in poor vision patients, which is less than equal to 20/50, and secondly, of the three, bevacizumab reduces macular thickness the least. Three anti-VEGF dosing regimens are generally talked about. Monthly dosing, which we know is pretty impractical. PRN or Prodinata, which looks at visual acuity or OCT-based criteria, very strict, but entails a number of visits. Treat and extend is something which the Western world is moving towards, where you treat even when the macular edema is resolved or the macula is flat, and then extend the follow-up by 2 weeks up to the point where the macular edema starts recurring again. So Retain compared a PRN with this treat and extend, and showed that there was no significant difference across the groups and they were more or less comparable. So the guiding principles for DME management, importantly for practitioners, is to look at the clinical profile. Obviously, fundus picture, OCT, FFA features, BCVA of that eye. But also look at the fellow eye. Look at the systemic profile. Rule out masqueraders. Also know the dosing history that the patient had, because if there was a deficit in that, that could be why it's recurring. Look at the patient factors in our context, compliance, financial issues. So clinical profile, look at what I call mitigating factors and encouraging factors, which is pure clean edema, subretinal fluid with without, suboptimal visual, which is 618 to 4/60. And if this encouraging factors is there, you can pursue a very aggressive treatment regimen. But if the mitigating factors are there, you can desist. And some of these are macular ischemia, subfoveal fibrosis, hard exudates in the macula, outer retinal tubulations, foveal atrophy, drill, VMT, and epiretinal membranes. So general rule of thumb mantra is monthly anti-VEGF injections. Still the patient is stable, acuity OCT unchanged with 2 or 3 visits. Wait and extend if those mitigating factors are there, or treat and extend if the encouraging factors are there. Inject and extend up to 2 months. If it's stable, you can extend up to 3 months. If it's unstable, you can go back to treat and extend. So that is if the dosing was inadequate. If it's adequate, you can switch it. And I mean, if you still have refractory edema, you can switch it from Avastin to Accentrix and vice versa. Examples of a patient who was refractory to Avastin benefiting from Accentrix and vice versa too, though that's less common. A lot of studies which have shown that switching drugs have helped. Elterly, Sudafix, IVT still there is a role. Ozurdex, the real USP is in vitrectomized eyes. This was purported for last 6 months. Actually, it does only for 3 months. Boyer studies showed the benefit in post-vitrectomy DME. But the real use, I think, comes from the MEAD study, which showed that refractory patients with history of laser or anti-VEGF treatment benefited with Ozurdex. Laser, this is the erstwhile green laser which we've used, but the 577 nanometer yellow laser has come in, and with sub-threshold micropulse technology with 5% duty cycle, you can actually even paint contiguously the macula with a laser, and it has shown benefit in some refractory DME cases. Moving on finally to PDR or proliferative diabetic retinopathy, panretinal photocoagulation is our standard of care. Anti-VEGF therapy has come in and has been used a lot as primary therapy, but we need to a rider of caution. It needs still fortification with PRP. One needs to be aware of fractional complications which can happen, can be used in post-PRP refractory PDR. Again, you need to be aware of fractional complications. Can be used as a preoperative adjuvant for macular TRD with active neovascularization. So to regress that neovascularization, get a grip on that, reduce the bleeding, and then operate after 3 to 5 days, and you can get good results, reduce bleeding intraoperatively. Can be used to treat neovascular of the iris or glaucoma. An injection, you can see, magically wipes off that anterior segment neovascularization. Protocol S looked at ranibizumab versus PRP and showed non-inferiority of ranibizumab vis-a-vis PRP. For PDR, greater equity changes, a better equity changes from baseline, lesser peripheral field effects, fewer vitrectomies for PDR with ranibizumab, less incidence of DME. All these were in favor of ranibizumab, but I think in the Indian context, PRP is more cost-effective, reduces number of visits, and there is, of course, permanence of effect. Finally, indications for referring for surgery or going in for surgery, non-resolving dense vitreous hemorrhage. Initially, classic teaching used to be 3 months, but now with advances in MIBS, I think within 1 month, people tend to go ahead with surgery. Macular TRD, combined mechanism, RDs, premacular hemorrhages, large, where you can't, where we are not, where hyalodectomy is not successful. Recurrent vitreous hemorrhage despite maximal PRP, and recalcitrant DM is also an indication. Like I mentioned earlier, also epiretinal membranes. So, in a nutshell, diabetic retinopathy diagnostics, OCT is the mainstay. OCT angiography is coming up. In leaps and bounds, fluorescein angiography is diminishing, but has still value. Anti-VEGF monotherapy is the mainstay of treatment for DME. Laser treated and treatment naive patients may still benefit from persistent anti-VEGF therapy. Aflibercept, ranibizumab have been shown to have greater efficacy than bevacizumab in patients with poor visual acuity less than equal to 20/50. IVT is still a role in pseudophakics, especially elders. Ozurdex for refractory macular edema and post-vitrectomy DME. Laser still has a role in non-center involving focal DME, where you can do focal laser. Micropulse can be used for refractory laser. Combination for diffuse DME. And if you're doing that, it's better defer laser and surgery vitrectomy for the hemorrhagic and tractional complications. Thank you.
Thank you, Dr. Anand, again for that wonderful talk, for summarizing all the concepts in diabetic retinopathy management within the 10 minutes time that was allotted to you. Thank you. I would like to call upon the next speaker, Dr. Rajanarayan. He will be speaking to us on another important vascular pathology, retinal venous vascular occlusions. Dr. Rajanarayan is currently the Director of Clinical Research at LVPI, and is also the General Secretary of the VRSI. Dr. Rajanarayan.
Yeah, thank you. Can you hear me and see my slides?
Yes, yeah, we can.
Yeah, so thank you all. Thank you to the organizers, Dr. Gopal Pillai. I'll be talking on retinal vein occlusion, and I would like to acknowledge my colleague, Dr. Rishikesh Kaza from our Vizag campus. I'll be presenting two cases, one on branch vein occlusion, another on central vein occlusion. And I have restricted myself on the different studies. So through these two cases, I would try to highlight the main points that we want to convey. So the first case is a 54-year-old male who has a history of hypertension for the last 8 years. And the last checked blood pressure was 164 by 100 millimeters of mercury, non-diabetic. And the patient had a sudden history of vision loss about a week ago, and noticed on waking up in the morning, the vision in the right eye was about 612, 618. And you can see on the fundus a lot of flame-shaped hemorrhages. And you can see the inferior temporal vein here is kind of occluded. And you can see the dense hemorrhages over there. And on OCT, you can see on the horizontal scan, the macular edema with subretinal, a little bit of fibrin. And on the temporal side, you can see the nerve fiber layer hemorrhages. You can see the high reflective dots and the cystoid spaces in the outer plexiform layer. And with all of these, a lot of us may be thinking, what's the best strategy here? We're seeing high reflective dots. Should we go with steroid? Should we go with anti-VEGF? Let's come back to it after some more slides. So in branch vein occlusion, you typically have superficial hemorrhages, which are the nerve fiber layer hemorrhages or the flame-shaped hemorrhages. But you can also get deeper hemorrhages, which are more round, blood hemorrhages. And but if you see them, it should kind of alert you to some other possibilities. In younger patients, you would tend to see more of deeper hemorrhages, and due to secondary causes, like in patients, in the younger patients, you may have either leukemias or homocystinemia or any other secondary causes. You may be seeing deeper hemorrhages in these cases. And what's the hallmark of retinal vein occlusion? In any case, you will also see the tortuosity of blood vessels. So tortuosity of blood vessels can be in different types. You can see them as arterial tortuosity, which are seen in different other conditions. You can have a venous tortuosity, which is typical in vein occlusion. Here there is a list of causes of venous tortuosity, and then you can have conditions where you can have both arterial and venous tortuosity. So all of these should be noted in the case of vein occlusion. While we see them very often, it's very important to look at the clinical signs and then only go in for, some of them are straightforward, but not all of them. So just don't end up giving anti-VEGF injections. You have to evaluate them clinically very carefully. What about the applied anatomy of the retinal vessels? The arteries and veins, they have a special relationship in the sense normally the artery is in front of the vein in most of the instances, but there are people who have the artery lying deeper to the vein, but they don't develop BRVO. In BRVO, the artery lies superficial to the vein in 100% of the cases. And the superior temporal quadrant is more affected because the number of AV crossings are more, and also typically the edema tends to gravitate to the macula in these cases, and they present with vision loss. I'm not going to go into the details of collaterals versus NVE, but broadly, collaterals are seen in almost every case. But NVE, if it is present, you need to take care of them specifically because they can cause vitreous hemorrhage. Typically, we do laser. What about evaluation of BRVO in the young, especially if you see those kind of deeper blood round hemorrhages, rule out blood dyscrasia, thrombophilia, coagulation profile, SLE, RA factor. So these are things, other secondary causes which you need to rule out. What about OCT? I think there are lots and lots of publications on OCT, various biomarkers and predictors. A lot of complications have occurred trying to understand what is happening. But as a general rule in ophthalmology, in retina, if you see edema, you should inject, whether there are high reflective dots or not, whether there is drill or not, whether there is ellipsoid zone disruption or not. If there is edema, the patient has the potential to improve. And that's the simplest and most reliable biomarker. The more the edema, more is the patient likely to improve with treatment. So here in this case, you have a patient with subretinal fluid and macular edema, give injection, and these patients do well. But if you have patients who would have, drill or inner layer infarct, or they can have ellipsoid zone disruption, yes, they probably may not gain 6/6 vision or 6/12 vision, but still they would improve. If they are counting fingers, they would improve to 660. If they're 660, they will improve to 618 or 612. So macular edema is the most reliable biomarker, the simplest biomarker. Here, just for example, I have given, as shown in the bottom picture, that the ellipsoid zone integrity is disrupted. You may not expect 6/6 vision in these cases. What's the role of OCT angiography? Not much in terms of decision making. Yes, it can show, it can document macular ischemia. It can tell you that the patient is unlikely to probably gain a lot of vision. But if you see macular edema, there's no doubt in giving them injections and giving them a chance for improvement. And then what about anti-VEGF versus steroids? The debate can go on. Here you can see high reflective dots too, the subretinal fluid, but after 2 Avastin injections, this patient became 6/6. All trials which have been done, different trials of different anti-VEGF drugs, and you compare with steroid implant, anti-VEGF wins hands down in terms of gain in vision. This is the Bravo, one of the first pivotal trials of anti-VEGF in branch vein occlusion. 18.3 letters gain in vision at 6 months. That's a huge improvement. You cannot have any better results than anti-VEGF in these cases of branch vein occlusion. The second case is of a central retinal vein occlusion, 30-year-old male, a younger patient. So this is to bring out a slightly different profile of a picture. Normally you see CRVO in elderly patients who have glaucoma. While hypertension is one of the key risk factors for branch vein occlusion, in the elderly patients, glaucoma is a key risk factor. But in a younger patient, you have secondary causes. Here, a patient presented with 1 month decrease in vision. The history-wise, there's nothing significant, but the vision loss is extreme in the right eye. And you see a lot of venous tortuosity, there is hemorrhages all around, and also slight disc edema. Fluorescein angiography is not indicated in these cases as such, but what if you do a fluorescein, you can look at the increase in the AV transit time. Even at about 30 seconds, veins are just about starting to fill up. So the venous flow is delayed in these cases. You can have blood vessel wall staining. You can see the petalloid appearance, cystoid macular edema, and some amount of disc leak. And you see the OCT again. You see these all the features: macular edema, subretinal fluid, high reflective dots. All these things can be looked at. But if you see edema, you have to inject. What about the investigation, especially if this was a young patient? You look at the battery of investigations which we did. All of them were normal, the first line. And then what you saw, the homocysteine level is extremely elevated. We also
something happened to the
Dr. Rajnarayan, I think your audio is not coming through.
Yeah, Raja got stuck, I think.
Gopal, somebody can ring him up.
Yeah, so Raja, what happened? You're muted. You're muted.
No, so I don't know, lost connectivity in between. So let me start from where I left.
But I think your screen is not shared yet.
Thank you. See my slides now.
Yeah.
So at this point of time, we switched to Lucentis or ranibizumab. Again, the vision improved, the macular edema probably has increased. Now we switched over to dexamethasone implant. And 1 month after dex implant, again edema is there. 3 months post dex implant, the edema has reduced, but then after 5 months, again it comes back with a vengeance. We repeated an FA to look for peripheral non-perfusion areas. We didn't find, and I don't have time to show all the images of fluorescein, but we didn't see much of non-perfusion, but still went ahead with PRP. And as this edema is still there, patient keeps on getting injections. Injection after this is year 3, patient's vision is improved now and the edema is subsiding. And year 4 is the time when everything is subsided. So what I am showing here is it takes a long time, CRVO, multiple injections. You may have to switch injections. And then there is, after Ozurdex implant, you may have cataract. Fortunately, this patient, especially a 30-year-old, you are worried about cataract. Lens is clear, but there is definitely a rise of intraocular pressure. Patient is on timolol at this time. So this is the baseline CRV on the left side, the final at 4 years. So with this, I'm stopping my presentation here. There are questions which can be answered, probably taken up by panelists. How many injections? What is the outcome? What's the role of laser? But again, these are chronic diseases, not a 3-injection disease that some of us tend to think of. And you may have to switch, evaluate systemically also. Thank you very much.
Thank you, Dr. Raja, for that excellent talk. Let's move on to the next topic, and we'll have the discussion after the next 2 or 3 talks. So I would like to call upon Girdhar sir for his talk on AMD and PCV. I don't think he requires any introduction, at least in this part of the world. He's been a mentor for most of us. Dr. Girdhar.
Is my slide seen there?
Yes, sir. We can see your slide, sir.
Okay, thank you. And I would be talking on wet AMD and PCV. It's a very basic talk. I'm not going into great details, but basically just to make a person understand as to how to diagnose, when to suspect, and what are the basic concepts in treatment. So, basically, what are the symptoms? Patients with wet age-related macular degeneration in patients above the age of 50 years may present with metamorphopsia or a central scotoma or defective vision. Now, if you see here, classically, you can see a small deep hemorrhage here. This is a subretinal hemorrhage where the retinal vessel is coursing over, a lot of drusenoid changes and a little bit of fluid and a membrane here. This is one of the classic presentations of a wet age-related macular degeneration. Another presentation is here. Here, when you see the macula, you can see the fluid right in the center. You can see this fluid mark. But apart from that, you can see this patient may be misdiagnosed as a choroiditis, looking at this yellowish discoloration. But when you see very carefully, you can see this again, a deep hemorrhage, a subretinal hemorrhage here. And what actually you're seeing here is the choroidal neovascular membrane right in the center. There's another presentation. This patient may be misdiagnosed looking at these exudates here as some sort of a vascular retinopathy or a macular branch retinal vein occlusion. But again, when you do a careful examination, you can see again a subretinal hemorrhage here, and even here, there's a subretinal hemorrhage. And what you're seeing here is actually the neovascular complex. So AMD has got various presentations, and when you do a very careful clinical examination, many of these cases can be diagnosed even on basic clinical examination. There are three presentations. One is what we call as a type 1 choroidal neovascular membrane, which presents as a very innocuous disease, actually with a serous retinal detachment. If you see here, there is a fluid in the macula. There's actually a serous macular detachment, which can be misdiagnosed as a central serous chorioretinopathy. OCT is very diagnostic. Actually, when you see the small elevation or irregularity of the retinal pigment epithelium and above the Brooks membrane, and there's a separation from the Brooks membrane, and when you see this hyperreflective area in between the retinal pigment epithelium and the Brooks membrane, in an area here, this is actually a very classic presentation of what we call as a type 1 neovascular membrane, where the neovascular membrane is growing between the Brooks membrane and the retinal pigment epithelium. If you do a fluorescein angiogram, you may see a vague area of hyperfluorescence here. The network may not be very clearly visible, but when you do an ICG angiogram, the network is very clearly visible. And this is a classic type 1 neovascular membrane growing between the Brooks membrane and the retinal pigment epithelium. Diagnosed by OCT, can be confirmed with ICG and fluorescein angiogram. Type 2 choroidal neovascular membrane has got the classic features of CNVM, which we have learned: the presence of a deep subretinal hemorrhage, exudation in the macula, and also fluid collection. This again is a very classic presentation of a type 2 choroidal neovascular membrane, which is pre-RP. This again can be diagnosed using OCT. In OCT, what do you see? You see a nice, well-demarcated, a hyperreflective area just above the retinal pigment epithelium, along with intraretinal and subretinal fluid. That's very important. Just the presence of a hyperreflective area alone may be many other diseases. But when that comes along with a cystoid edema or intraretinal fluid, when the neovascular membrane has break through the external limiting membrane and the presence of a subretinal fluid, all three put together form a classic presentation of a type 2 neovascular membrane. So the type 3 neovascular membrane was described in the previous talks, both in FFA and the ICG. Therefore, we come to the type 3 neovascular membrane, which actually starts intraretinal and goes subretinal, and then finally it goes sub-RPE. There are three stages in this, and this is at the type 3 neovascular membrane, and this again can be diagnosed using both OCT and other investigations. Now, in a clinical examination, you see a large area of pigment epithelial detachment. And if you see this hemorrhage, it's slightly different from the hemorrhages that I showed you, because in type 3, in early stages, you see intraretinal hemorrhages apart from the subretinal hemorrhage. If you do an OCT, one of the most important characteristics of a type 3 is the presence, in the established type 3, is the presence of a large pigment epithelial detachment. And this actually is usually scalloped, like what you see here. And you may also see a break in the retinal pigment epithelium if you do a very careful examination, because the neovascular network is growing from here into the subretinal space, into the sub-RP space, and this is where the whole place is happening, and that's why you see a break in the retinal pigment epithelium at that point of time. So when you do the ICG, as he had shown you earlier, shows you what is called the hot spot. And this hot spot is characteristically seen right in the center of the PED, because that's where the neovascular complex is present. And this again is very diagnostic of a RAP presentation. In a fluorescein angiogram corresponding to that area, you may see an area of leakage like what we see in a classic neovascular, choroidal neovascular membrane. So I pass the OCT through this particular point, and you can see this break. As I explained to you, the neovascular complex is growing from inside outside through that retinal pigment epithelium break. However, this should not be confused with certain innocuous pigment epithelial detachments that we see in practice. This is a drusenoid PED. This is not a fibrovascular PED. Why is it a drusenoid PED? Because you can see this uniform elevation and uniform hyperreflectivity, and you see these hyperreflective dots here, which are actually what is now described as drusen ooze. Of course, clinical examination is also useful, but this should not be misdiagnosed as a wet AMD, and the patient should not be treated. Coming to the treatment is basically anti-VEGF therapy. We have the bevacizumab, we have the aflibercept, and we have the ranibizumab now. So what are the two parts in the treatment? We have what is known as the induction phase, where we give monthly injections till the macula gets dry. So we give multiple injections, what is known as a loading dose, which may need up to 3 to 4 injections initially to reach what we call as a dry macula. And once we reach that, we reach what is called as the maintenance phase, where what we have achieved initially is maintained in terms of vision and also in anatomy, and as well as the anatomical changes that we have achieved. Therefore, this requires prolonged treatment. It's a chronic disease, and patient education is very, very important. Initially, ideally, we need to follow up these patients every month after we have achieved a dry macula, and patients can be treated on a as-needed regimen or on a treat and extend philosophy, although many of the initial randomized trials use a monthly or bi-monthly treatment, which is not feasible in routine clinical practice. What is a pro-re nata treatment? Pro-re nata treatment is, and we follow up the patients on a very regular basis. And as and when there is a fluid, we inject and follow the patient again a month later, and then again don't give any injection when the macula is dry, and treat as and when there is fluid collection, either in the subretinal space or within the intraretinal fluid, or both in the intraretinal space and in the subretinal fluid. Therefore, this is how we follow up these patients on a regular basis, treat as and when necessary, so that the patient is able to maintain the same visual acuity that he had initially. A new concept is treat and extend, which is being followed extensively in the Western world, and this probably is very useful in some selective set of patients. What we actually do in treat and extend is that once we have achieved a dry macula, we next have the next follow-up about 6 weeks later, and even though the macula is dry, we give an injection and then delay the follow-up again 8, 10, 12 weeks like that, so that the number of visits are reduced, but treatment will be done irrespective of whether the macula, in spite of the fact that the macula is dry. And as and when there is a recurrence, we shorten the follow-up by about 2 weeks. Therefore, this is a new concept which is being followed extensively. So that is what about age-related macular degeneration. Coming to polypoidal choroidal vasculopathy, it's a variant of wet age-related macular degeneration. It has got various classic presentations like what I've shown you here. It can present as a subretinal hemorrhage. This is quite a large one, but you may even get a much smaller hemorrhage than this. So it can present in various forms of a subretinal or a sub-RP hemorrhage, or a combination of both. It also can present again with a serous macular detachment here, as you can see here. But then sometimes if you see this patient, if you see this very carefully, you can see this subretinal hemorrhage here, which again tells you that this is not a case of central serous chorioretinopathy, but this is a case of a variant of wet age-related macular degeneration. The third type is what we call as an exudated type, where we get a lot of exudation into the macula. And this is a particular case where you can see so much of exudation here. This again is a very classic presentation. Therefore, you can get a hemorrhagic form, you can get an exudative form, or you can get a combination of both hemorrhagic and exudative form, as these are some of the very classic presentations where clinically itself, you can say that this could be most probably a case of polypoidal choroidal vasculopathy. Coming to the investigation, ICG angiography probably is the key investigation or probably diagnostic. And you can see here, what does ICG angiogram show? ICG angiogram shows what we call as nodular hyperfluorescence in the early phases of the ICG angiogram, occurring within the first 5 minutes. Usually it starts very early and is maximum seen between about 3 to 5 minutes. And these nodular areas of hyperfluorescence are surrounded by an area of hypo. And this hypo is basically because of the presence of some fluid or blood. So you can see here very characteristically the nodular hyperfluorescence, which is very diagnostic in ICG angiography. However, ICG angiography is not available extensively, and today we have got very important or very key diagnostic markers in OCT, and a large percentage of polypoidal disease can be diagnosed with a good OCT examination. So what are the various types? Or this was also told by Dr. Mahesh, where you can get this notched PED. This is very diagnostic. The area of the notch is where you see the polypoidal vessel. The polypoidal vessel is here, and that's where you get this area of the notch. So the polypoidal vessel leaks fluid and lifts the rest of the pigment epithelium. That's the concept of this notched PED in PCV. You can have a peak PED, you can have a thumb-shaped PED, and most importantly, seeing this hyperreflectivity on the roof of the PED is again a very diagnostic sign. Unlike other characteristic forms of wet age-related macular degeneration, PCV is mainly has a serous macular detachment. You never see intraretinal fluid in polypoidal disease. Very, very rare. Probably in very chronic disease, but you never see. Therefore, when you see a large PED like this, with a lot of fluid like this, you're possibly dealing with PCV. Another important finding, which was again so told, is the double layered sign, the separation of the two, which I had explained earlier in the type 1 CNVM. Now, if you pass the OCT through the ICG angiogram, there's a large network here, and the area of the network is what causing the double layered sign. This is where the neovascular complex is, between the Brooks membrane and the retinal pigment epithelium. And this neovascular complex ends in an area of polypoidal dilatation, and that's where you get this pigment epithelial detachment. And this polypoidal dilatation leaks fluid, and that's why the rest of the pigment epithelium is raised here. So anatomically, using OCT, you can actually describe the pathogenesis as of the polypoidal disease. Coming to treatment, the most accepted treatment based on the current trial is the combination therapy with anti-VEGF injection. However, anti-VEGF monotherapy is extensively practiced across the world because PDT facilities are not available in many parts of the world, and and therefore there are probably, I would say, selected situations where PDT protoporphyrin therapy is very effective in the management of polypoidal disease. We use it in many patients with small polypoidal lesions in the macular area, especially in the subfoveal and the juxtafoveal area. Small lesions which do not have a very large network of vessels, and patients who do not respond well to anti-VEGF treatment. These are probably the very important indications today for the use of combination therapy. You can see the pre-treatment ICG angiogram, and you can see the post-treatment ICG angiogram where there is a complete regression of the polyp with one cycle of PDT with anti-VEGF injections, where we give a loading dose. We do the PDT, give the anti-VEGF injections within about 12 to 24 hours, and give an additional anti-VEGF injection a month later, and one more a month later. This is known as the loading dose regimen, which probably is the best way to manage some of these patients with polypoidal disease. However, as I told you, monotherapy is also being used extensively. What are the advantages of monotherapy? Probably it's not an invasive treatment like a laser treatment. What is the disadvantage of monotherapy? Patients may need frequent injections, and that becomes a challenge in the management. And some of these patients may show an initial response, and later the response to injections are a little wavered or probably not a good responder, as we keep saying. So this is a patient here. This again is managed on a loading dose treatment where we initially give multiple doses of anti-VEGF till the macula gets dry, and subsequently follow these patients regularly and treat them as and when necessary. So this is a patient who has been receiving aflibercept, And you can see here, patient has been showing good response to treatment and has been receiving injections once in 3 to 4 months to maintain the same visual acuity. And this is very helpful in patients who are one-eyed, patients who have got a very large network. And these are situations where probably monotherapy may be an ideal form of a treatment. This again is a follow-up of this patient. So thank you all for your kind thank you, and I hope you could find this presentation useful.
Thank you, sir. Thank you for that wonderful presentation. I think we have covered 3 important topics now: diabetic retinopathy, venous occlusion, and AMD PCV. And so we will have a bit of discussion again. I would like to request Lalit sir to preside over the short discussion.
Yeah, I think 3 important diseases have been covered, which all the retinal specialists see. The only thing I can summarize is that diabetic retinopathy, the main role of doing OCT today is to rule out surgical issues. Because first and foremost issue should be, if you have, like it was shown very nicely, if you have significant VMT or a tractional maculopathy, then surgery should not be delayed in such patients, especially if the vision is poor. You see, VMT alone cannot be an indication. It has to be a combination of VMT plus decreased vision.
Yeah, I'm in the
then only patient to surgery. Is it audible? Yeah.
Yes,
so,
sir.
Yeah.
So yes, sir, it's audible.
OCT plays a significant role in the investigation of diabetic retinopathy. Then coming to DME, I think everything was summarized very nicely. A lot of studies were summarized, but basic thing is to distinguish between center involving and non-center involving. Non-center involving, go ahead and do laser. Center involving, choice is between anti-VEGF injections and steroids. And I think that both pros and cons have been very well mentioned. PDR mainstay is still laser, but anti-VEGFs have an additional role also, because anti-VEGF can be usefully used in patients of PDR where resolution is less, or the neovascular component is in a very sensitive area with very good vision. Then I think there is a role of anti-VEGF in PDR also. But having said that, I think laser still a good PRP, I think is the mainstay. Surgery, I would like to tell everybody, the audience, is that surgery should not be too much delayed in patients of complications of PDR, because the more you delay, difficult the surgery and poorer the visual results. This is what I had to say. In case anybody wants to add anything to diabetic, I think Giri or Meena, any of the panelists can add.
Yeah, I mean, I think from a Lalit, from a general ophthalmologist point of view, I think in a patient with a 6/6 vision, the main important thing is to find out whether the patient has a vision-threatening retinopathy or not a vision-threatening retinopathy. That is a severe NPDR, early PDR, or even a PDR with a normal visual acuity. I think that's very important, basically, to differentiate between a vision-threatening retinopathy and a not a vision-threatening retinopathy. And they refer these patients at the appropriate time. And even from a point of view of a postgraduate student and a trainee, I think it's very important during PG they learn as to how to differentiate a vision-threatening retinopathy from a non-vision-threatening retinopathy.
For the benefit of the postgraduate students attending this program and the young comprehensive ophthalmologists, I'd like to say that laser is still not an outdated treatment modality. And when you choose intravitreal injections, it is necessary to explain to the patient that the treatment does not end with a single injection. The need for more injections, the strategy that you're going to follow has to be explained to the patient. The need for follow-up also has to be emphasized. The need for combination therapy of combining with laser in our own clinical setup, most of us have seen that they give very good results. It's also necessary to emphasize the importance of complications in addition to the severe systemic adverse effects, the local ocular complications, especially the pressure spiking that can occur in a vein occlusion patient who has a primary open-angle glaucoma or a glaucoma suspect. It is necessary to have baseline pressure recordings And the IOP recording has to be done at each subsequent visit, and a change of IOP, difference of 5 between both the eyes or an increase by 10 in the injected eye has to be considered significant. Dr. Giridhar has very nicely brought out all the clinical features of AMD and PCV, and also the necessity for patient education in this matter.
And as far as I think vascular block, Raja did an excellent job by taking 2 cases and summarizing everything. And I'm happy that he did not go into details of all the studies. But suffice to say, all patients of vascular block, we should rule out glaucoma. That's a associated, association in around a quarter of 25-30%. And CRVO and VRVO, BRVO is a very good natural history, and people should not be rushing to treat BRVO very aggressively. And as far as CRVO is concerned, we should rule out the causes of especially in young patients. You see, all patients of vascular block should be subjected to a cardiac evaluation as well as some vascular evaluation. Primarily, we want to rule out any blockage elsewhere also, because it's blockage in the eye, but you should rule out carotid vascular disease or any heart disease. That should be done. And as far as role of injections and the steroids, I think, as I said, BRVO has a reasonably good prognosis. Especially in good vision, we should not be very aggressive to treat BRVO. CRVO has to be treated very, very aggressively. And you see, any kind of macular edema or neovascularization in patients with CRVO. Also, do not forget, review iris and do a careful gonioscopy and a slit lamp examination in patients of CRVO. And CRVO, if treated aggressively, I think, you can save the eye and save good vision also. However, a lot of these patients with CRVO may present sometimes with NVG. Here, I think a good laser as well as, I think, tube implants, they give very good results in patients who have NVG. Plus anti-VEGF. You see, whenever NVG presents, we give anti-VEGF, try to laser these patients, and ultimately, if pressure does not control, then tube implant. These 3 things have to be done simultaneously in patients who have NVG. Comments from Meena and Giri?
Yeah, I agree with you that, I think this ruling out primary glaucoma, I think, is very important. And for that, you have to examine the fellow eye. That's very important. And many of these patients have NTG, normal tension glaucoma, especially elderly patients, they have NTG, and therefore fellow eye examination for a deep cup is very important. As far as neovascular glaucoma is concerned, I think neovascular glaucoma in PDR is more important to manage than in ischemic CRVO, because in PDR, the visual prognosis is very good. Some of these patients come to us with very good vision with early NVG, and they have to be managed very aggressively. I think that's very, and it should not be treated like a normal glaucoma. It's an emergency. It should be attacked. The day the patient comes to your clinic, it has to be attacked, especially if it is a very early case. Give anti-VEGF injection immediately. If there is a media is clear, then you can even go ahead, and if you want to do a fluorescein angiogram, you can do that and give aggressive PRP immediately. So I think if you do that, I think a substantial number of patients recover very well with good vision. Unfortunately, in CRVO, the NVG has to be treated, but unfortunately, the visual prognosis is very bad because they are all patients with ischemic CRVO with a visual acuity of CF 1 meter, 2 meters. But PDR, I think it's worthwhile doing a very aggressive treatment.
Like what Dr. Raja showed in one of his slides, a serum homocysteine level of 79. Homocysteine as a risk factor for central retinal vein occlusion is very common in our country. And this thromboembolic risk factor can easily be modified by dietary modification and supplementation of B-complex vitamins. So that is another factor. I take home message for the postgraduate students that serum homocysteine level should be estimated in patients who come with you for retinal vascular occlusion.
Lalit, I wanted to ask you, actually in good old days, these sort of what we used to call it papillophlebitis. These young CRVOs, we used to call them papillophlebitis, and we used to give them a course of oral steroids. We used to give them a course of young CRVOs, we used to give them a course of oral steroids.
I know.
I personally think even now there is a role for that. Basically in young CRVOs, what do you say?
You see, CRVOs in young is a different chapter altogether.
Yeah.
In fact, 1/3 of these patients, I end up giving steroids, whereas in rest of the 2/3, you see, I do not. That is my, analysis of young CRVOs. And like Meena said, a lot of these young CRVOs may have elevated homocysteine, so you load them with mega doses of, say, B12, that and folic acid. That generally helps. Apart from injections, you see, injections is the main role, but we have to give this treatment also. So all young CRVOs, we don't give steroids, but around 1/3 maybe
Lalit,
you end up.
May I add something, Lalit?
Yeah.
Yeah. To continue what Dr. Girdhar was saying, actually, if you go to Duke Elder, it mentions central eels as an entity. That central eels is actually the CRVO of the young. And that, as Lalit is saying, there's a significant number of patients who are there. So actually, you need to classify your patients of CRVO into two. Those who are under the age of 40 and those who are in the older age group. In the older age group, you don't usually find anything other than glaucoma and hypertension as the main added risk factors. But in the younger patients, you need to do a complete profile for causes of acquired and congenital hypercoagulability syndromes before you stop. And many of them will respond to anti-inflammatory treatment. So whether you're talking of...
we did mention about the...
Yeah, so there's an entire list of things that needs to be done, which includes anti-cardiolipin antibodies, ANA factors. All inflammatory causes have to be ruled out, and all congenital hypercoagulability syndromes need to be ruled out. So that is important in CRVO under the age of 40, 45.
Yeah, that's what I said. CRVO in young has to be treated, managed differently compared to CRVO in elderly. CRVO in young, I think Raja also showed that slide, what all has to be ruled out. So regarding the last talk that was, in this session was on wet AMD and PCV. I don't think so. I need to add anything to what Giri very, very nicely, pictorially built up the story of type 1, type 2, and type 3 CNVMs. Nothing more needs to be added. The only thing I would add is that in PCV, Giri showed very good example. All of us should study the PED characteristics very, very carefully. You see notch PED, thumb shape PED, or tall PED, peak PED. So that adds a lot of value if you don't have an ICG facility. Although ICG is the gold standard of diagnosing PCV, but short of ICG, in case you don't have, I think OCT with good study of PED can do it. Other thing is that you start suspecting PCV, as was being told, either large hemorrhage or exudation. Most of these patients will not have characteristic drusen as other people would have. Or sometimes, people who are refractory to anti-VEGF, then again we start thinking of PCV. So whatever Giri said, that you start treating anti-VEGFs, with anti-VEGFs, all these ARMD patients, if patient is not responding, patient does not have drusen, or patient has this OCT characteristics, which Giri very nicely showed, start suspecting PCV and put them on, either monotherapy or PDT. PDT nowadays is not easily available, so a lot of retina people are, continuing anti-VEGF treatment primarily. I think here is one disease where Eylea has a more important role compared to Avastin or ranibizumab. Any comments from the panel, or otherwise we can hand over to Dr. Gopal and Dr. Manoj.
Thank you, Dr. Lalit sir, for those inputs. I think it was we got a lot of practical inputs from all the senior faculty. We had a good round of discussion. Let's move on to the next topic. I would like to request Dr. Mangal Dogra to be one of the pioneers of ROP care in our country, and he'll be speaking to us on the topic of prematurity.
Are my slides can be seen, my projection?
We can see your slides.
Yes, sir.
Okay. Okay. At the outset, I would like to thank everybody from Cochin Ophthalmology Club, especially Gopal, giving me this opportunity, in fact, to speak on my favorite subject. And of course, I was there last year when Giridhar called me, and I had given a oration on the same topic and with a big gathering. And so I'm really thankful. And I would like to share some of the important issues concerning retinopathy of prematurity, since it is for the postgraduate and the general ophthalmologist. As we talk of retinopathy of prematurity, this is becoming a leading cause and the new cause of childhood blindness in India. Because if I go back to my younger days, this disease was hardly seen, and it was one para-retrolental fibroplasia somewhere as differential diagnosis of retinoblastoma. At this time, we have a much bigger problem. We are seeing many more babies because heavier and older infants are also developing ROP because of the various reasons, the neonatal care not being that optimal. And the most important risk factors from any point of view is, of course, the prematurity itself. That means the lower the gestational age, lower the birth weight, more the chances. And in our country, especially the oxygen therapy, which is an unmonitored oxygen. That's why we have such a high incidence, because we don't have that many saturation monitors, as well as other blenders and other facilities. I have also highlighted some of the other things. Sepsis is common, anemia is common. That's why more blood transfusion are given. And we have a difference between babies born like in a tertiary care center and outside babies, because they are given unmonitored oxygen, they tend to develop much more ROP. I think I have projected some of the Indian studies which have looked at the Indian scenario, the incidence of ROP. It is as good as anywhere else in the world. And still, even 2000 up to 2012, it is almost similar what we had seen, our study as well as Lingam Gopal's study way back. We published first studies in 1995 in Indian journals back to back. So it is almost similar. The most important aspect which I would like to highlight is ROP screening. You see, this is not a congenital disease. Child is not born with ROP, and screening aims to identify the treatable disease. That is what the whole crux of problem is. And there's a very narrow window for screening and treatment. That is what I would like to emphasize to all here, that delay in screening causes blindness or severe visual impairment. If you miss that window, it's going to be over for the child and for the family. And of course, it has the biggest medical legal implication. You should be aware of that. Probably some of the highest awarded medical legal cases, even from the Supreme Court, which goes into crores, are for ROP these days. And you can imagine the economic and social burden of childhood blindness is immense. And this is one baby which is of a high-risk pregnancy, survived and now blind, so it could be a big problem. So in India, why heavier babies are also developing ROP? I'm not going into that. This was one landmark study when Anand Vinekar was with me as a student. He did this as thesis under me. And you see, look at this. 16% of the babies of severe ROP above 1750 grams. And 6.5% were above 2 kgs. And almost 23% of babies were above 32 period of gestation. So this has big implication for as far as the screening guidelines were concerned. I think studies like this, I'm not projecting others. There are other studies from Subhadra Jalali and from the group from Arvind, which also emphasized on the same point. And you see, Western guidelines, US 1530 weeks, we would miss so many babies. So now the Indian screening guidelines from 2018 onwards are 2 kgs birth weight, because in most of the rural patients, period of gestation is not even known. But if it is known, it is 34 weeks of period of gestation. So that is very, very important for everybody, all ophthalmologists or students to remember. And the simple rule of thumb is that it must be screened before 30 days. That is what 30 din roshni ke. This has been given by Subhadra Jalali. She's very passionate about it. So remember this, that this has to be within that period, screening has to be, and documentation is very important. It has to be on uniform basis. And for this, the plus disease identification is very important, which itself is a subject. If you have something, what I have shown here, as one side is pre-plus, which has not reached the standard photograph, which is on the other side. This is dilatation, tortuosity of the vessels. And sometimes you have engorged vessel anteriorly, and which says, so that becomes a severe plus disease. And the documentation is according to the international, so that's how it is so uniform. And the more posterior the disease, like the zone 1, which is twice the distance from disc to the macula, you draw a circle, is the most severe disease. And zone 2 would be that you would draw another circle up to ora serrata, and most of the disease you will see in zone 2. Zone 3, even if you are seeing something, they regress of its own, it's not going to be much of a problem. And extend, or the circumferential thing, is something which will be in clock hours. So stage 1 is when you have just a line between vascular and avascular retina. And stage 2 would be when this line gets a volume. And then there is the extra retinal proliferation like this, which has happened, then it becomes stage 3. If there is a extramacular detachment, which has not reached fovea, then it is a stage 4A, and 4B once it has already come in and involved the fovea. And stage 5, of course, is when there is a total retinal detachment. I would like to say here that in aggressive posterior ROP, which has been only sort of defined in 2005 in a revisited classification of it, is something which is seen most often in 50 to 60% of outborn babies, or approximately 50% babies in our country. This is one of the biggest challenges. This happens either in zone 1 or posterior zone 2. And you don't have any stage. You may have few vessels, which might be in the form of loops, flat vessels, and it will go directly into retinal detachment. So it's very, very important for all of us to identify this. That's why it is important. So what are the current treatment for ROP? Close monitoring of oxygen saturation levels. I have put it in the different color here because this is what has to be done across. This will bring down the retinopathy in our country. And the peripheral retinal laser ablation is still the standard, gold standard. And anti-VEGFs are coming in. They are coming in bigger way. And the vitreous retinal surgery is required for stage 4 and 5. So the indications are in the type 1 ROP needs treatment. These are the indications which changed in 2003. So I'll not go into detail, but if you have any stage of ROP with plus disease in zone 1, you'll treat all. This second one, zone 1 ROP without stage 3, I think this is hypothetical. I don't know how it came. If you have a zone 1 ROP, it will not be without plus disease most of the time. And you treat anything in zone 2, that means stage 2 or 3 with plus disease. And of course, I have boldly put here aggressive posterior ROP, which forms a major chunk, especially for our country. So if you have a situation like this, still it has not reached the plus disease and is stage 2, you may follow. But if you have something like this, already a plus disease, and of course it's not, and you have already something much more, then you treat this one. And the laser treatment is usually delivered through the laser indirect ophthalmoscope and in a confluent burn, like seen here, and you will have beautiful regression. Look at it, it's 2 weeks. These vessels, they will come back to its normal. Everything disappears, and 90% attain favorable outcome. That's the beauty of laser. And the laser treatment is, as well as is possible inside the incubator through the wall. This has become as a big thing for me. This was published by me, and my observation, which I have shown this video maybe all over the world, that many people treated this with during this COVID time. They screened through this, they treated through this because they were afraid that so I think even they got idea in anesthesia to do something similar for general anesthesia because of what we did long time back. I think this is another one which we must remember, that we should use the same 532 laser, which is available for other vitreoretinal diseases. Mostly it is available. Diode laser is not available. Western world taught us that diode laser is must. No, we have shown it in two elegant studies here and few more studies published from elsewhere. And now everybody uses this 532 laser. So this has equal efficacy as well as no more incidence of cataract or other formation, and gives the equal efficacy. So that is very important. Like this one treated here, you can see this is with the 532 laser, the disease has regressed so well. We have a problem with APROP, aggressive posterior ROP. With laser, in our own series way back, published in 2009 in Retina, we had almost, you see, 29% unfavorable outcome. And this could vary anywhere in various studies from anywhere from, say, something like 15% to 40%, even 50%. So these are the cases perhaps we need anti-VEGF. Otherwise, the laser has high rate of successful outcome for type 1. And it is a finite treatment, definitive. Once you have done that, it has regressed, it will not come back. But the problem are different here. So, but zone 1 and APROP, as I said, they have lesser success rate, so they need anti-VEGF. And disease sometimes progress despite your confident laser. There also you need this. Sometimes pre-operatively, it is very vascular, you may need it. And then in many countries, also here in India, as an excuse, it is being used where the laser is not available, or when the ophthalmologist to perform is not trained, they may give this. So I think these are some of the, and anti-VEGF in ROP are slowly becoming more acceptable all over the world. Somehow, I think we were more apprehensive for APROP and ROP in zone 1. They are being used more and more. And most of the time, in many situations, especially in these cases, laser may be required, but you can watch. If it is getting vascularized, you may not do it. There are still systemic adverse events are the concern. And another problem is that we may have recurrence. You need a long-term follow-up. I have not gone into because this is a subject in itself for us to discuss. The current surgical approaches for 4A, 4B, and 5R scleral buckling, which is done very rarely. Now the incidence come very, very low of doing this. And because lens-sparing vitrectomy has taken up, and lensectomy and vitrectomy. Lens-sparing vitrectomy shows 60 to 85% success rate in 4A, 4B. There are multiple studies, in fact, many of them from our own country. And like this, our own case. You see, you can see how vascular it is. It is almost like trying to forming a fold. You do lens-sparing vitrectomy and how nicely it goes back. Stage 5 is a problem. You don't let them go there. And you don't want to seed them because they have a very poor outcome despite heroic surgery. Only less than 1/3 will show reattachment, and hardly they have a very poor dismal outcome. Very, very rarely there'll be a child who will have a ambulatory vision. So don't let them go there. And we do have a third epidemic of ROP blindness at this time because of the, I already mentioned in the beginning, variable quality of neonatal care, especially the new NICUs and SSNCUs. Every district in our country has that. And use of unblended and unmonitored oxygen. And even there are a lack of ROP screening programs, especially in these SNCUs and smaller places. And there is also not that much awareness, of course, which is increasing. So we are happy about that. Lack of trained ophthalmologists. This part is also increasing. I think when we used to be in earlier days, this was hardly any people. So, well, friends, I can go on. I try to sort of make it like a summary here that we need to identify treatable ROP with timely screening. That 30-day strategy, 2 kgs, remember that. This is for everybody across. Then manage treatable ROP promptly with laser. If there is a laser person who can do the laser, that's really preferred. But in zone 1 and APROP, you may need anti-VEGF. I have not talked which anti-VEGF. And lens-sparing vitrectomy is, I think, most important early intervention. And if you can do it at 4A, it will not go to 4B or 5, and it will have a very good outcome. And stage 5 require lensectomy and vitrectomy and has dismal outcome. So don't let them go to stage 5. That is your responsibility. If it is treated early, and you have done laser, it may regress. Even if it is progressing, you catch at 4A, 4B with lens-sparing vitrectomy, they'll do much better. So thank you, friends, for your patient hearing. I'll be happy if you will have any questions later on. Thank you very much.
Thank you, Dr. Mangat Dogra, for that excellent talk. I think we'll break for a small discussion here because this is an important topic. I would again like to request Dr. Lalit Verma to preside over a short discussion.
I think nothing to add what Mangat has already said, but just to re-emphasize 2 points which I think I also learned and audience would have gained, that screening is the hallmark, because today you cannot, no ophthalmologist, what to talk of retinologist, everybody, you see role of imaging also is coming up. I think Mangat would agree that people who cannot, there is a ultra wide field red cam and low cost cameras also available, which NN team has developed also, along with this team from Forus. They have developed a very nice low cost wide field photography team. Zone 1 and APROP nobody can afford to miss, but this is one thing which will progress and child will become blind in front of you. So therefore, one thing is screening by everybody. Everybody has to learn that art, and if you don't have photography equipment, then indirect everybody, all ophthalmology, which I keep telling everywhere, that indirect thermoscopy art every ophthalmologist should have, because telling that this patient does not have ROP is again a very big challenge. And I am happy that Mangat spoke about anti-VEGFs also, because anti-VEGFs are assuming, especially in zone 1 as well as aggressive posterior disease, where laser does not have good results. These anti-VEGFs do, and God forbid that stage 5. Nowadays, I don't see anybody doing stage 5 surgeries. Most of the people do only till stage 4A or B, lens sparing vitrectomy. Any points by Giri or Meena or anybody else?
I'd like to say one point here. The most important thing is when you're doing a screening, check for plus disease. If you see tortuosity of vessels, or if you have a doubt that this is significant tortuosity, let the patient rush to a place where work is done for that. You may be doing only screening, because you can miss anything else, but it doesn't matter. It will matter if you miss plus disease. So if you must not under any circumstance miss the fact, and if you feel that there is tortuosity, send the patient. A false alarm doesn't matter, but an alarm which is missed will be catastrophic.
The screening in ICU usually takes place because it's under the pediatrician's care. But what has received a back burner status is the post-discharge follow-up of these children. Their refraction, correction of amblyopia, screen correction, and long-term follow-up has taken a back burner status. So it is necessary that we counsel the parents, emphasize to them the necessity to bring their children back for follow-up. Sometimes they may be staying at a distance, and the difficulty of bringing a little baby for such a long distance to the center, which has done the ROP screening, may cause them to procrastinate, but it is necessary for us to educate them. Secondly, people working in a center like mine, which is a standalone ophthalmic center, not a multi-specialty setup, when we go for screening, do not hesitate to go for screening when the call comes from the NICU, even if it is locked down. You take your indirect ophthalmoscope, your laser, and if necessary, the anti-VEGF, everything can be given in the NICU itself. So these are the 2 points I would like the postgraduates and the comprehensive ophthalmologists to take back home.
You see 2 points again, even during sorry Mangat, even during Corona, ROP was one disease which, everybody was still treating, and, you could leave aside other diseases which could take a back seat, but ROP, Mangat would agree, was one disease which everybody was still, taking care of. And the other point is that, which saddens me sometimes, is the art of indirect in teaching institutions is taken a back seat, which I would reiterate that every ophthalmologist, irrespective of whether it's a retina person or not, should learn that indirect thermoscopy. Yes, Mangat.
I'm really thankful to Dr. Lalit, as well all 3 panelists here. Lalit has emphasized 2 things which is very important about the screening and also the digital screening. I think we have cheaper cameras available. I didn't touch it for the lack of time, and a lot of work being done in this front. And this may become that ultimately it will be the nurse screening in the NICU itself, and they will do it. And then we will be just looking at the images. So it is going to happen, and we'll have to see that era. And also emphasizing what Dinesh told about the plus disease. I think if somebody picks up plus disease and see dilated tortuous vessel, that's very important. I think don't sit on that. Just send it. Just send it that very moment. And that is very, very essential. And of course, Meena talked about the long-term later follow-up. I say many a times, once your job is done, 6 months down the line, you have seen it has regressed, you have done good job, attach them preferably to a person who is more knowledgeable about a pediatric ophthalmology, because they develop there's so many things, myopia, amblyopia, nystagmus, so many things, and they will do very well under their care. And of course, you can keep on seeing them maybe annually subsequently. So I'm grateful for the comments, and many things can be done. But in our country, it's a challenge, and it's a great thing that, as Dr. Lalit has mentioned, everybody must screen. Indirect ophthalmoscopy, at least they should know, as well as digital screening will be a big thing, which is becoming cheaper everywhere.
Dr. Mangat, in this regard, it's this further screening. The important thing is not the ones who got lasered only. Yeah. Anybody who's gone through ROP screening is to be considered as potential candidate for having long-term ocular problems.
Yes,
so
absolutely, very important point.
Patient who has screening. It is not patients who had laser. It's all patients who come under the prematurity group need to be screened almost till adolescence before you say, okay, if nothing happens, chances are something will happen. It'll either be, they'll have a high refractive error, they have a higher incidence of keratoconus, they could have other problems. So they need to be followed up every 6 months, even if no laser is done. And that is what needs to be stressed. So this is what I
very important. Yes, very important point you've raised. I think all spontaneously regressed ROP, as others, those who have no ROP but premature, definitely we tell them that come back at 1 year and have an examination done. If they are doing fine, then we do call them at 3 years again. I think that's very important. So another point which you raised, a very important issue that we definitely need, they have much more incidence. Even the premature babies have much more incidence of, as you said already, myopia, keratoconus, and other comorbidities.
Okay, I think with this, we hand over back to Gopal and Manoj.
Thank you.
Thank you, sir. Thank you, sir. Thank you once again for that wonderful discussion that we had. We'll go to another important topic now. I'd like to request Dr. Dinesh Talwar to speak on endophthalmitis.
Thank you. I must thank the organizers, especially Gopal, for inviting me for this program. You know, when you take the name endophthalmitis, it sends a shiver down the spine of any cataract surgeon, but actually any ophthalmic surgeon. Because of endophthalmitis is a dreaded eye and sight-threatening intraocular inflammation of the inner coats of the eye. That means the retina and the choroid. Those are the areas getting involved here. Now, the causes could be exogenous or endogenous. And exogenous can be postoperatively, either as a result of cataract surgery or some other intraocular surgery. And in today's world, following anti-VEGF agents, then you can have bleb-related endophthalmitis, or you could have post-traumatic endophthalmitis. These are all exogenous. Or you could have endogenous endophthalmitis from the bloodstream. Post-traumatic is worse because the penetrating injury results in more aggressive organisms directly seeding into the vitreous cavity. Now, the causes of various types of endophthalmitis are different. With post-operative endophthalmitis, remember Coagulase negative staphylococci as the most important cause. But in our country, fungi are another important cause. And if you have cluster endophthalmitis, think in terms of Pseudomonas. Bleb-related endophthalmitis, keep in mind streptococci, Streptococcus pneumoniae. Post-traumatic endophthalmitis, keep in mind Bacillus cereus. These are the most important causes, and that's what makes them so scary. And when it comes to endogenous endophthalmitis, you could either have fungi in the form of Candida Or you could have multiplicity of organisms, both gram-positive and gram-negative ones. And in intravenous drug abusers, you could have the bacillus species. Now, when do you suspect endophthalmitis? Now, you've done a surgery and the patient comes on the first post-op day. Is there anything that can make you keep a high index of suspicion? Well, the most important symptom in this condition is increasing pain. You don't expect patient to have a lot of pain on the first day following a surgery unless there has been some untoward event. So if the patient is complaining of a lot of pain and you can't explain that, keep in mind endophthalmitis. But what about the subsequent period? The first day has gone by, and subsequently during the post-operative period, the patient suddenly says, look, I was doing okay, and now I'm having a decrease in my vision and an increase in pain. This is a situation where you must suspect endophthalmitis. So a deterioration following an initial improvement is reason to suspect endophthalmitis in your patient. We're talking of post-operative endophthalmitis right now. But also keep in mind that there are 25% of patients who can complain of decreasing vision but don't have much pain and yet have endophthalmitis. So this must be kept in mind. Now, what are the most important signs? Those were symptoms. What are the most important signs, both in the first day and on the subsequent post-operative days? The most important is an increase in ocular reaction compared to the surgeon's own gold standard. The surgeon knows when he does surgery, whether he gets 1+ reaction, 2+ reaction, what kind of cells does he see, usually in his cases. So it's very important to be familiar with your own reaction on the slit lamp. And if the reaction is more than what you normally see, you must keep endophthalmitis in mind. The other important thing is a decrease in glow on distant direct ophthalmoscopy. This has a very high sensitivity, but a low specificity. Why? Supposing somebody has corneal edema, the glow will get affected. So it's not so specific for endophthalmitis. But if you see on indirect ophthalmoscopy any exudates in the vitreous cavity, this has a very high specificity for endophthalmitis. So now let's come to this. If you see hypopyon, if you see vitreous exudation on indirect ophthalmoscopy, in any of the settings we talked about, we are more or less convinced we are dealing with endophthalmitis. Do we need an ultrasound? No. The ultrasound does not help to make a diagnosis of endophthalmitis. Why? Because the ultrasound will show you exudates or membranes or any opacities much later. The inflammation has to be there for some time before it becomes evident on the ultrasound. But the ultrasound can help you in your surgical decision making, not for making a diagnosis of endophthalmitis. Sometimes you may have a lot of reaction, but no hypopyon. So then what do you do? Now, if you see no hypopyon, but you see reaction, you see a decrease in vision, check for vitreous exudates. If you see vitreous exudates are present, your diagnosis is confirmed, you're dealing with endophthalmitis. If you're not got any vitreous exudates, chances are you're dealing with a sterile inflammation. But once in a while, you have this problem. The pupil is not dilating. Now what do you do? Well, this is a situation where if your reaction is very severe, 3+ or more, and your vision has deteriorated significantly, say it's less than 6/18, I would, in today's scenario, consider an intravitreal antibiotic in this situation. If the vision is better than 6/18, I may give a first trial with very intensive topical therapy to see whether the patient is responding. Now let's see a picture like this. You have a small hypopyon here, you have some KPs. This is more likely to be an infection. If you have something like this, there's more of corneal edema. The periphery is more or less clear. There's no hypopyon. There may be reaction there. The reaction is more than normal. This is more likely to be TAS. So how do you differentiate TAS, which is toxic anterior segment syndrome, from infection? Let's see the parameters. The onset, TAS starts in the initial period after surgery, within the first 12 to 24 hours. Infection, unless it's extremely severe, is usually in the 4th to 7th day, but could occur anytime up to 4 weeks. What about pain? Pain is not common with TAS, but it is an important feature of infection. Vision drop will happen in TAS also, but not as severe as what you would see in infection. If you see a PR inaccurate, you're not dealing with TAS. Severe lid swelling, chemosis, hypopion, these are signs that you're now dealing with an infection, not a toxic reaction. Now, supposing you see that the glow is absent, that's not a good sign, and that's not TAS. The vitreous is usually clear in TAS, haze is there in infection, and if the exudates are more yellowish, then you're really dealing with infection, not with TAS. So these are some of the ways in which you can differentiate TAS from infection. But remember, the human body doesn't behave like a book. So there could be places where there's an overlap. And the important thing is, when in doubt, err on the side of infection, not on the side of inflammation without infection. So what are our objectives for management in postoperative endophthalmitis? We want to control the infection, then we want to clear the media, we want to prevent any iatrogenic complications, and of course, we do want an improvement in visual acuity. So how do we do that? The mainstay of treatment, you're all aware, is intravitreal antibiotics. I'm just repeating the same. The usual antibiotics we give are vancomycin and ceftazidime because we find this the safest. Adjunctive treatment includes topical steroids and antibiotics, cycloplegics, topical and systemic steroids later on after the first 24 to 48 hours, and intravenous or oral antibiotics which penetrate well into the vitreous cavity. The caveat here is, supposing you have an infection occurring, say, within 36 to 48 hours. This is likely to be gram-negative. This is one situation where I would change from ceftazidime to amikacin, which is more powerful. We've been having fear of amikacin because of the risk of macular infarction. But when you have to take the fear of infection, of severe infection into consideration, it's better to give vanco and amikacin in these patients. And if you have infection which has occurred in the first 24 hours, go straight for a vitrectomy if you can. And if you can't, this is where I may consider giving intravitreal meropenem or a combination of tazobactam, piperacillin, in addition to vancomycin. And the adjunctive treatment remains the same. Now, this is a chart which the AIOS in conjunction with CIPLA has created, and which tells you exactly how to give the intravitreal antibiotics. I'm told by Dr. Gopal that this video would be later on available, so you can copy from there, but you could even get this from the AIOS or from the CIPLA people anytime, and everyone should have this in his operating theater so that you don't have any problems of concentration when you make your antibiotic. You have to dilute the antibiotic, and you shouldn't make any mistakes in that. Now you've given your antibiotic, you've given your intravitreal antibiotics. Now what happens? Well, three things can happen. Either there's no worsening, or there's improvement, or there is worsening. If there is worsening, there's no question about it. The patient needs a vitrectomy. So when you give the intravitreal antibiotic, it's extremely important that you prepare the patient that, look, you need to go to XYZ. He will probably give you, do your surgery, inform the doctor that I'm sending this patient, and then either you say, let him follow up with that doctor who's going to do the surgery, or if it's nearby, wherever he has to go, you say, I will see you, and if you need surgery, you may just need surgery the same day. So prepare the patient for surgery when he gets the intravitreal antibiotic. So if you have a patient like this day 5, some reaction, 6:18 vision, no hypopion, no definite vitreous exudates. Now here, I would start with very intensive topical antibiotics, cycloplegics, and see if I get a positive response, I may continue with that. And this is what happened here. So it turned out this could be a low-grade endophthalmitis also, but it responded to it, and he was lucky. But This is a patient who's got an intravitreal antibiotic, receives the intravitreal antibiotic, is improving. You see the next day, the hypopion's disappeared, glow is there, glow is improving, and patient is settling down. So this is the kind of patient whom you can, here you have the patient, and you see that it's cleared over a period of time. Lucky patient responded to an intravitreal antibiotic. But this is the other one who did not seem to improve. It's an inadequate improvement, and this is the kind of patient where you may consider doing a vitrectomy. And this is what happened. He didn't respond and finally was taken up for a vitrectomy. Improved after vitrectomy, but was unfortunate to get a secondary rhegmatogenous detachment. So just because a patient's become initially okay does not mean you stop following up, because if he gets a detachment, he can again be managed. And this patient was managed with VR surgery with silicone oil and did well. Now, this is to show you that sometimes we can undertreat. This patient had endophthalmitis on day 1. And it was considered an intravitreal is enough, and his surgery was not taken up on day 2. There's a delay here. On day 3, this is already the position. You almost lost this eye because of a day's delay. So if you feel that you've given an intravitreal and it was on day 1, either you do the surgery, do vitrectomy on day 1, or next day, if he's not better significantly, go ahead and do surgery. Remember, there is no role of multiple intravitreal antibiotic injections except in very unusual circumstances, and referral after the first injection is probably the best policy. We don't want the patient, of course, if the patient reaches this level, you may have no choice but to give multiple intravitreal antibiotics to save that eye. That's all. Results of vitrectomy are gratifying. You can achieve more than 660 vision in over 80% of patients, and the IOL can be retained in most. There is now what we call radical vitrectomy, which we do in patients with severe endophthalmitis, where on ultrasound you find exudates right up to the retinal surface, or there's no PVD on during the vitrectomy, or if there's a fungal endophthalmitis. These patients can do well with a radical vitrectomy, which is a complete vitrectomy, in which you create a posterior vitreous detachment if required, trim the vitreous skirt close to its insertion at the ora, remove the cyclitic membrane, and the IOL removal if required. The importance is that this prevents hypotony during the initial period of ciliary body shock and helps early rehabilitation of the patient. And you can see this is one patient who did very well after a radical vitrectomy. This is another patient after radical vitrectomy, did well, and then was a phakic, got a glued IOL, and doing very well, 6/9 vision. Now, the important thing is that with radical vitrectomy, you could actually bring a large number of patients, more than 60%, to more than 6/60 vision, whereas with a normal vitrectomy, a conventional vitrectomy, in severe endophthalmitis cases, we could do that only in 1 out of the 12 cases. So this helps. So this is just to point out that in many cases, you will be able to save your patients. So as far as acute postoperative endophthalmitis is concerned, the messages are intravitreal antibiotics followed by topical, intensive topical and systemic antibiotics, and steroids as soon as you believe you're dealing with endophthalmitis. Refer for vitrectomy all patients who show inadequate response to intravitreal injection in the next 24 hours. Core vitrectomy for moderate severity of endophthalmitis, and a radical vitrectomy for severe endophthalmitis. And with this approach, you can save most of your patients. Just a word about endogenous endophthalmitis, 4 or 5 slides. There are 2 major scenarios in endogenous endophthalmitis. One is clinically moribund patients with septicemia and an immunocompromised state whom you see in the ICU or admitted, and they are severely sick. The second is ambulatory patients who will give you a history of IV dextrose or some IV drugs, some recent past history of infectious illness. Keep this history in mind when you see a patient who looks as if he's having endophthalmitis, but no injury. The endophthalmitis can be anterior or posterior, and in both the situations can be focal or diffuse. The mainstay of management, now this is why it's important to know this, The mainstay of management here is systemic antibiotic in meningitis doses of that particular antibiotic. Whichever antibiotic combination you're giving, it should be the meningitis doses that you're giving. If it's still not responding and you have very severe vitreous reaction, you can give intravitreal antibiotics in addition. And in very, very severe cases, non-resolving, vitrectomy with silicone oil can give you a positive response. This is just to show you one patient with a focal endophthalmitis, which happened, the patient had a history of enteric fever for which she got a dextrose drip for 15 days. And this is what we found out when we took the retrospective history. And this you can see, this was a combination, this was a fungal and bacterial endophthalmitis which responded to treatment. This is another patient who, again, he got blunt trauma in one eye, was being managed with mannitol. And then the other eye, he came with a loss of vision and had this kind of endophthalmitis. This patient responded, and this is the picture inside. You can see the exudates, and these exudates responded very well to a combination of monosef, vancomycin, and ciprofloxacin given for 2 weeks. So adequate treatment must be given in these patients. Ladies and gentlemen, the important thing is you must have a high index of suspicion for endogenous endophthalmitis, especially in your ambulatory patients. Otherwise, you will miss this. You'll consider this trauma and consider this is a vitreous hemorrhage, and you may make this mistake. So be careful. Elicit a history of past infection episode or of IV fluid use. Manage aggressively with high-dose systemic antibiotics and topical adjunctive antibiotic. Keep in mind fungal or atypical organisms in poorly responding patients, and give intravitreal antibiotics or vitrectomy with silicone oil injection as a second or third line of management. With early diagnosis and appropriate management, you will be able to successfully manage most of your patients. Thank you very much, ladies and gentlemen. Thank you. To the moderators, if there are any questions.
So thank you very much, Dr. Dinesh Talwar. That was an excellent talk as usual. Can you stop sharing? Endophthalmitis is again another off topic. So we'll just have a little bit of discussion on this before moving into the next topic. Dr. Lilith, please.
I think there is nothing to add except to re-emphasize some points. I think Dinesh started with the word shiver. I think that is the right word. Every patient who develops any unusual reaction after a routine surgery should definitely send shivers down the spine of a operating surgeon. The more the shivering, better is for the patient actually. The second word which caught my attention was delay. Nobody should be delaying, because every day of delay in management of endophthalmitis affects the prognosis. I think he showed very nicely 2 or 3 examples, both in vitrectomy also, as well as interval injection. And there could be 3 kinds of scenarios, like he also said. One is clear-cut patient endophthalmitis, showing the chart what he showed the telltale signs of signs and symptoms. One is clear-cut tasks which can improve. Other is in-between case. In-between case is always better, you see, to err on the side of infection, because I have not seen any eye being lost because of interval injection, rather than, you see, I've seen eyes getting lost or worsened if injection is delayed. The other thing I think he has emphasized very nicely, that we always keep depending on vancomycin. The sensitivity of CAFTA towards gram-negative is on the decrease, is nearly 60 to 65%. And hence, if it is very fulminant day 1 and you're suspecting gram-negative, better now to shift from CAFTA to Amica or Tezo and Peptidase. The repeated injection, I'm never in favor of that. You keep giving repeated interval injections. Better is to prepare these patients for early vitrectomy. Early vitrectomy also has a better outcome compared to if you do a delayed vitrectomy when the cornea becomes hazy and AC becomes full of exudation. One thing which I think needs special mention is a lot of these patients are fungal, required repeated injections despite a good vitrectomy also. And other thing is about the IUL removal. A lot of these patients may necessitate IUL removal also if the patient is very severe, or if the bug is something like P. acne, which is residing in the capsular bag. I think with these points, I will request Girdhar or Meena to add a couple of points more if they have.
I'll just add a few points. I would say that even a few hours delay can make a lot of difference in the management. Number two is that Dr. Dinesh had very clearly spoken about the sterile inflammation. But unfortunately, when you get a patient with a sterile inflammation, you're always having a doubt. So if you have a patient with a suspected sterile inflammation, clear cornea, mild inflammation, and if you have a doubt, call the patient the same day in the evening. If you've seen them in the morning, see them again in the evening. And if it is an infection, it would have progressed. It would have definitely progressed. The vision would have come down, and you will find new signs, and that gives you an indication that you need to interfere immediately. The third point is TAS, sterile inflammation, infection. These are three different things. Classic TAS is entirely a different thing because you get a end-to-end corneal edema, significant increase in intraocular pressure. So that's an entirely, but sterile inflammation, especially when you had a little traumatic surgery, when you had a little bit of posterior capsule rupture, or when you retain some cortical matter, you may end up with a sterile inflammation. So we got sterile inflammation, you got TAS, you got infection. So confusion comes between sterile inflammation and infection. And basically, we should not delay management in these cases. And as Lalit said, when in doubt, inject. Don't delay injection, because I think you don't lose anything by giving an intravitreal injection.
As emphasized by the panelists, it is when in doubt or on the side of infection. I'd also like to emphasize that daily anterior segment images of the patient has to be taken, and you have to sit across the patient and his caregivers, show them what is it that you're dealing with, so that a good understanding develops between you and the patient. Secondly, we are at present not dealing with the classical coagulase negative staph aureus, which the EVS study taught us to handle. We are dealing with very virulent organisms, especially gram-negative escape group of organisms, especially Acinetobacter baumannii. This endophthalmitis with this organism is on the rise and very, very difficult to treat, very quiet eye, not painful. A recurrent repeated infection, even after 4 or 5 vitrectomies, the infection recurs. They have brownish or chalky white hyperpan, corneal infiltrate, severe vitritis, macular edema, and despite 3 or 4 vitrectomies, the infection recurs again and again, and these are pan-drug resistant organisms. So that also has to be borne in mind.
I think back to the Gopal and.
Thank you very much, sir. Dr. Meena will be talking on macular surgery, the vitreous retinal interface diseases. As postgraduates, we have all, I have basically heard Meena Madam talk multiple times on ILM peeling, etc. And, over to you, Meena Madam.
Thank you, Gopal. I have titled my talk as Vitreomacular Interface Pathologies, which by itself as a standalone disease has gained significant importance with the availability of OCT, that more and more cases of vitreomacular traction, macular hole, epimacular membrane is being diagnosed, not only from the vitreoretinal surgeon's point of view, but also from the cataract surgeon's point of view, where the presence of a macular pathology will limit the visual prognosis. And if a diagnosis of these conditions can be made when the patient is being worked up for cataract procedure, then a combined procedure can be done for this patient, and the patient can be rehabilitated in a single sitting. So for the benefit of the postgraduate students, let us look at the common vitreous attachments. We all know that the vitreous is attached at the vitreous base, the peripheral margins of the optic disc, at the posterior pole, at the margins of the fovea, and around the retinal veins. And when a posterior vitreous detachment occurs, when the site of attachment of the vitreous to the retina is strong, it can result in avulsion of a retinal vessel or tearing of the retina. There may be other abnormal areas of attachment of the vitreous to the retina, especially in a patient who has a prior retinovitreo-retinal pathology. For example, the patient has a choroiditis, a prior trauma, etc. In this situation, there will be abnormal areas of adherence between the vitreous and the retina. So if you look at the story of a normal posterior vitreous detachment, it goes through the stages of liquefaction and syneresis of the vitreous, followed by weakening of the interfacial adhesions and a spontaneous separation of the posterior vitreous cortex with or without separation of the internal limiting membrane. This occurs in about 10% of the patients by the time you are 50 years of age, and as your age increases, the percentage of patients with the posterior vitreous detachment also increases. Now let us look at the story of the anomalous posterior vitreous detachment. Here the liquefaction occurs very fast, while the weakening of the interface adhesion is tardy, and when separation of the posterior vitreous cortex occur, it can result in a lot of pathological conditions. This is the IVTS, the International Vitreoretinal Traction Society classification of an anomalous posterior vitreous detachment. It has divided the vitreous separation into a partial thickness separation where there is a vitreoschissus or a small layer of the posterior cortical vitreous still remains adherent to the retinal surface. In this situation, the patient can develop a premacular membrane, and the traction, in addition to being axial or anteroposterior, also has a tangential component. And when this tangential traction is centrifugal or outward traction, it tears the retina at the center of the fovea, resulting in a macular hole. And when the traction is centripetal or towards the foveal center, it results in a macular pucker. When there is a full thickness anomalous posterior vitreous detachment, but it is only partial and still adherent at the site of abnormal vitreoretinal adhesion, when it occurs at the peripheral site, it can result in a retinal tear or a retinal detachment. At the optic disc, it can result in a vitreopapillopathies, especially in a patient with a proliferative vitreoretinopathy. It can result in a significant amount of bleeding into the vitreous cavity. And in conditions in the macula, for example, an exudative wet age-related macular degeneration, the presence of an adherent vitreous with traction will definitely aggravate the condition. And we have seen that in our patients in whom we inject intravitreal drugs. The injection of the intravitreal drug itself may cause a posterior vitreous separation and may cause lessening of the macular edema. So this is a patient who has a vitreomacular traction, a very narrow vitreomacular adhesion, less than 1,500 micron in size, where there is both axial and posterior, where there is only axial and posterior traction. This is another patient in which there is a tangential component, which is centrifugal, resulting in a macular hole. And the macular hole progression can occur through various stages when there is persistent foveal traction and perifoveal detachment, pseudocyst formation, which are impending macular holes, progresses on to stage 2 macular hole, where there is deroofing of the pseudocyst at the macula, followed by infiltration of fluid vitreous into the retina and enlargement of the macular hole, where it progresses to stage 3. And then finally, the posterior hyaloid separates in stage 4 macular hole. So if you look at the comparative clinical features between all the stages of macular holes, the clinical symptom will be metamorphopsia, and the amount of visual symptoms may vary from a mild visual loss and distorted images to significant visual loss, especially in a patient with a large macular hole which has been there for a long period of time. We can differentiate the various stages of macular hole by a good biomicroscopic examination, optical coherence tomography, and fluorescent angiography and other tests are very rarely needed. I would say that they are not needed in the diagnosis of macular hole. So what is a natural cause of a macular hole? All macular holes may not require surgery. We have seen that in 60% of eyes, spontaneous vitreofoveal separation, relief of traction occurs, and a patient with an impending macular hole may have spontaneous resolution, which is seen in about 8 to 10% of the cases. And 1/3 of these cases show significant visual improvement. 40% of cases progress to small macular holes within a few months. Stage 2 holes progress to larger stage 3 and then stage 4 macular holes. The development of a complete posterior vitreous detachment is a favorable sign that the progression of the hole will not occur subsequently. What about screening of the fellow eye? If one eye has a macular hole, it is important to screen the fellow eye, especially if this eye has had a poor prognosis after surgery. And if you can document the presence of vitreomacular traction, such a patient needs at least a 6-monthly follow-up and an optical coherence tomography. And with the occurrence of a posterior vitreous detachment in the fellow eye, the risk of progression to a macular hole in the fellow eye decreases significantly. So if you're looking at macular hole surgery, if you surgically manage a patient with macular hole, there are several controversies. It may be too much to go through in the small lecture of 10 minutes time. How soon to operate, how old, whether to peel the internal limiting membrane or not to peel the internal limiting membrane. Can you peel the internal limiting membrane without staining it? Do you invert the internal limiting membrane flap? Do you plug the macular hole? Do you use an autologous retinal transplant to close the defect in the macula? are adjuvants like such as the autologous serum necessary in these patients? Do you tamponade with gas? And if you're using gas, how long is the cone positioning? There are several controversies with respect to the surgical management of macular holes. What I would like to say is that when you operate on a patient with macular hole, any stage of macular hole will definitely, we can result in closure of the macula, give a closure of the macular hole and some amount of visual improvement in the patient. And any operable retinal condition has to be operated on. You do not know what's going to happen to the fellow eye in due course of time. So if you look at the preoperative predictors of visual recovery in the patient, the most important is the preoperative vision and the size of the macular hole, and there are various indices to look at the hole form factor, which will assess the it's an important factor on which the prognosis and closure of the macular hole depends. There are other indices which will also determine the extent of tangential traction or the anteroposterior traction in this hole, and the configuration of the macular hole, the mean base diameter, the minimal diameter of the hole, the thickness of the hole. All these are factors which should be taken into account to prognosticate to the patient, and preoperatively, once you have done your OCT and diagnose the presence of a macular hole, it is necessary to have the patient sit next to you and explain to him that these are the condition, these are the prognostic factors that you have, and this is what we are going to do. So why do you need to peel the internal limiting membrane during macular hole surgery? It's to improve the anatomic and visual results of macular hole and minimize the face down positioning, release whatever tangential tractions, which is responsible, the centrifugal traction, which is responsible for the hole. And what are we peeling? We are peeling the vitreoschissus, that is the layer of adherent posterior cortical vitreous. The presence of any epiretinal membrane that is there over the macula has to be peeled, and along with that, we are also peeling the internal limiting membrane. So the length of face down positioning in patients who undergo gas tamponade, this is more than the macular hole surgery. The patient, especially the elderly female patient, most of them are obese. Face down positioning is a nightmare for these patients. And how long should the patient lie prone? And in the present society where the elderly parents stay alone and the children are abroad most of the time or in their place of work, there are no caregivers to look after the patient in the postoperative period. The face down positioning is a real nightmare. And what is it that we are achieving by filling the eye with gas? If it is the buoyancy of the gas that is acting, it has been shown by very significant studies that the buoyancy has very little effect in closing the macular hole. We are looking at the interfacial tension. For the gas bubble to maintain adequate interfacial tension, the globe has to be filled with gas bubble if you do not want to position your patient. And in the phase where the gas bubble is shrinking in size, positioning of the patient becomes very important. So we are looking at, initially the duration of prone positioning was for about 5 to 6 weeks. It became shortened and shortened to no face down positioning, and this was done whenever the macular hole surgery was combined with the cataract surgery. In the combined procedure, positioning was not necessary because the two important complications of gas in the eye is the early development of cataract, feathery opacities in the lens, and second is a rise in intraocular pressure. So in patients with no positioning, most of these studies showed that it was combined with cataract surgery. We move on to another technique where no gas tamponade is done. This is a technique I've been following for the last 7 years. This is using autologous blood taken from the patient's antecubital vein. A 3-layered plug is formed with 2 layers of autologous blood, which sandwiches the peeled internal limiting membrane. And this is one such case, which shows that after induction of the posterior vitreous detachment, staining and delineating the posterior hyaloid face with transferon acetonate, a good vitrectomy is done, followed by staining of the internal limiting membrane with brilliant blue G. I'm using an instrument called the Finicity Flex Loop to raise up the flap of the internal limiting membrane. A wide area of ILM peeling is done, extending from arcade to arcade. The internal limiting membrane in macular hole surgery peeling is like breeze. It is easy, and compared to in a patient who has a significant diabetic macular edema and has undergone laser photocoagulation, where the peeling of the internal limiting membrane is difficult. In this situation, it is very, very easy. And after the internal limiting membrane has been harvested, too much of the membrane in the situation has been harvested, the first layer of the plug is introduced into the well of the hole. And if you see in this situation, when I'm trying to trim the membrane, I take the pull the membrane out of its attachment to the edges of the hole. So I am left with the free internal limiting membrane graft, which I stuff into the hole to form the second layer of the macular plug and again layer it over with autologous gluconated blood. In these cases, with this the surgery ends. There is no fluid air exchange or gas tamponade. This condition, this type of surgical procedure has given me very excellent results, and I have not used gas in any of my macular surgeries for the last 7 years. So why do we need adjuvants? Adjuvants are necessary in complicated macular holes, especially recurrent holes, myopic holes, traumatic holes, chronic holes. In this situation, you need whatever armamentarium you have in a hand to ensure that hole closure occurs. So to summarize the current treatment strategies for macular holes, almost all macular holes we can achieve surgical success. The hole closure rate varies from about 90 to 99%. Internal limiting membrane peeling slows the visual recovery, but it causes closure of the macular hole. We can use either a peel off the internal limiting membrane, use it as an inverted flap, use it as a plug, etc. The duration of positioning depends upon the surgeon's technique. It can vary from a few days to no positioning at all. You can use either a short-acting or a long-acting gas. Usually a short-acting gas such as sulfur X, hexafluoride or air is used, or no positioning without gas tamponade can also be done. Long-term results in macular hole surgery is also very good. Postoperatively, you have to do a postoperative follow-up optical coherence tomography in your patients. The closure can be a type 1 closure where there is a very good closure with good visual recovery, and I've shown here a type 2 closure where you have a flat open type of closure. The type of technique that I showed, this kind of flat open closure can be avoided. Even if there is a type 1 closure, there may be a situation in which the outer retinal layers do not heal completely, as in this patient. You can see in the second slide, second picture, you can see that there is a defect in the outer retinal layers, and in this situation, the visual recovery will be poor. So all this has to be, OCT images have to be taken, and you have to speak to your patient. So let us look at the second part of the talk, which will lead with epiretinal membrane, where the interaction is both anteroposterior as well as tangential. And here the vitreomacular adhesion is usually broad adhesion, and these patients also have significant amount of decreased vision and metamorphosia. And when they are symptomatic, it is necessary to operate on them. The surgical management is again release of vitreomacular adhesion. You observe the patient. If he does not have any visual problems, you give them a home Amsler start. And in those patients who cannot use the home Amsler, you just ask them to close one eye and focus on some straight line, for example, the grill of a window, and then see whether there is any distortion. We are looking at 3 methods of treatment: observation, surgical management, and pharmacological vitreolysis. The surgical management is indicated when the patient is symptomatic. These are 2 symptomatic patients. In one patient, the video on the right side shows significant vitreoschissus. I have stained the posterior cortical vitreous with triamcinolone acetonide. That is the white area, and the epimacular membrane is being peeled. And in the second video, I'm removing the layer of posterior cortical vitreous from the macular surface. And once you have done a significantly good area of peeling of the epiretinal membrane, then again you stain the internal limiting membrane with brilliant blue G. And once the internal limiting membrane is stained, you peel the internal limiting membrane. You can either use a blunt spatula, or you can use a Finicity flex loop to raise the flap of the internal limiting membrane and peel it off the retinal surface. Here again, the peeling of the internal limiting membrane is not difficult. And once you have raised a good flap of internal limiting membrane, you can peel it off. In the second video on the right-hand side, you can see that after peeling of the adherent vitreoschissus, part of the internal limiting membrane has also come down. Only shreds of the internal limiting membrane is available, which is peeled off to smoothen out the retinal surface and improve the visual recovery in these patients. So pharmacological vitreolysis using a recombinant enzyme, the oxyphosphine or Jetria. Studies have shown that good results in up to stage 2 macular hole and release of vitreomacular traction can be achieved. However, this is associated with serious adverse effects such as macular hole formation, retinal detachment, and reduced pixel acuity, the exact reason for which is not known. And to summarize, macular interface pathologies have gained significant importance. This is a disease process affecting mainly older people disproportionately. In an asymptomatic patient, you can follow up the patient and the old treatment paradigm to watch and wait is only for the asymptomatic patient, and surgical treatment gives very good results for a symptomatic patient. I thank you very much for your kind attention.
Thank you, Dr. Meena, for that excellent talk and videos. I would like to, we can have a small discussion again here. I would like to request Dr. Lalit Verma, sir, to preside over a short discussion.
Excellent, Meena. You have in fact covered everything about VR interface disorders. One point which I have emphasized is that all patients of VMT do not require surgery, because ultimately what I think, and I think you have also said very nicely, that it is ultimately metamorphopsia or best corrected near and distance visual acuity or scotoma. They only determine. You see, patient may have a scary looking VMT, but vision may be very good. So such patients do not require surgery at all. I think you have very nicely told that. You also very nicely told about the concept of anomalous PVD, which explains all these disorders. In contrast to endophthalmitis and you see detachment and other things, this is one disorder which in COVID era does not require urgent attention. These people can wait for some time. You see, I'm just trying to make a comment because we are all talking in COVID era. Same is true for ERM surgery. ERM surgery, ILM peeling, I personally think is not a 100% part and parcel of ERM surgery. If it comes, well and good. If it does not, I in any case do not I do not keep doing scratching of the ILM. So I personally feel that ILM is not 100% required management in ERM, because a lot of these patients, you see, once you peel off the ERM, patchy ILM also comes along with it. But very nice videos. And other thing is that people have to, do those surgeries described by you, that 2 plugs, one by blood and one by ILM. Because I do not have personal experience, I will ask Giri and other people to comment on that. I still do flap or peel in most of the patients with macular hole. Giri, are you there? Or anybody else?
Yeah, I'm there.
Yeah, Giri.
Yeah. I mean, I agree with you, Lalit. I mean, I do the flap. I don't stuff the macular hole. I do the flap. And what I want to say is that I think one has to very clearly define that not all macular holes require a flap or a plug. There are, many macular holes will close with a simple internal limiting membrane peeling. Therefore, I think we have to, based on experience, we must choose which are the sort of eyes where we need these sort of procedures. Because all said and done, if a macular hole can close with a routine, nice ILM peel, and in an ILM peel, I think the most important thing is you need to remove the ILM from the edge of the macular hole. That's very important. You should not leave a rim of ILM at the edge of the macular hole. You should remove the ILM at the edge of the macular hole. I think if you do that sort of a procedure in quite a substantial number of cases with small and medium-sized holes, you can achieve good closure. So I still use gas. I use SF6 gas most often. And I don't use air. I use SF6 gas. I use prone positioning. I've reduced significantly, maximum about 48 to 72 hours. It's very small, probably only 2 days.
I agree with all this, Giri, what you have spoken. The only message I would like to convey for all the general ophthalmologists after hearing excellent talk by Meena, that today, irrespective of obese lady or neck problems, no macular hole should be refused surgery at least. We can do this simple surgery with reasonably good results. Yes, Meena, you want to make some comment?
For a small macular hole, which is less than 1000 micron in size, this kind of macular plug technique is not necessary. These are for large holes with 1400, 1700, even 2000 micron in size, very large holes for which even if we do an ILM peel or an inverted ILM flap, you may still be left with a flat open configuration and poor visual recovery. So this technique is basically meant for large holes of more than 1000 micron in size and not for the small hole.
Yeah.
Okay. I think we can move on, Gopal.
Let's move on.
Thank you.
Yeah. Prashant has been waiting all day.
Yeah, Prashant has uploaded.
Yeah, I'm ready. Shall I?
Yeah, retinal detachment comes later, very late.
Thank you, Gopal. At the outset, I would thank Cochin Ophthalmic Club, Dr. Sai, Dr. Gopal, and everyone for giving me this wonderful opportunity. I'm supposed to cover a very elaborate topic, that is retinal detachment. Within 12 minutes, I would try to do justice to it as well. As we are aware, retinal detachment is a separation of neurosensory retina from retinal pigment epithelium at a potential embryonic space which exists by the subretinal fluid. The fluid from the vitreous pours into the thing and causes a retinal detachment. Basically, there are 4 types: regmatogenous, where a regma or a hole is responsible; traction retinal detachment; exudative retinal detachment; and a combination of any of these 3. So regmatogenous retinal detachment, regma means break. So there is a full thickness break as shown in this schematic fluid, in this diagram over here. So a liquefied vitreous, the fluid flows from the vitreous through this hole into the subretinal space, leading to detachment. While in a tractional retinal detachment where there is no hole, in fact, there is a pull by the fibrovascular or some tissue on the surface of the retina, leading to pulling of the NSR from the RP. And that is why you see a this type of a tented type of a appearance. While in exudative retinal detachment, there is neither a break, neither a traction, but the fluid accumulates in this potential space because of the secretion either from the retinal vessels or from the choroid or from the both, and you can have a bullous type of a detachment over here. And in a combined detachment, what happens when the pull exceeds the capacity of the strength of the retina, there is a tear, and therefore it is called a combined retinal detachment. Pathogenesis for any retinal detachment can be the most implicated factor is posterior vitreous detachment. Dr. Meena has absolutely beautifully told about it, so I would not be dwelling on it. The second component which is responsible is a vitreoretinal traction, and the third in a exudative variant is the exudation. PVD, I will just run through it. As we are aware, as the vitreous separates from the retina, it can pull off at predisposed lesions like a lattice or some pigmentary clumps or a abnormal vitreoretinal adhesions at the normal sites of physiological adhesions, or in a fibrovascular proliferation having an adhesion, it can tear off, and this leads to the development of traction. While a static traction we can have because of vitreoretinal forces can be dynamic in nature or static. Dynamic happens because of the vitreogenesis as elicited in this program. I will not just run through this particular slide because I don't want to bore you further with the pathology. So how do we differentiate? Basically 3 types. This is a short history about it. The regmatogenous has a break in it. There is a convex configuration of a undulating dulles or folds on it, and it usually extends up to the ora serrata. While in a tractional retinal detachment, it has a concave configuration, and the detachment is usually restricted to the point of attachment, that is the tractional points, and it is usually not extending up to the periphery or to the ora serrata. While in exudative variant, one has to remember it is convex in nature, most importantly, but this can be this convexity varies with the positioning of the patient. So that is called shifting of fluid. Examination we need to do right from visual acuity to pupillary reaction, intraocular pressure, slit lamp examination, importantly indirect ophthalmoscopy, and ancillary tests like fundus photo, fundus fluorescent angiography, B-scan, and OCTs. In mostly we need the help of this in a bad media or in an exudative variant. So visual acuity, once the macula is involved, naturally the visual acuity comes down. Slit lamp examination is important to look for associated comorbidity like having a cataract, if you have a cataract, or these are the subtle signs which might give you a clue which needs simultaneous management while you are doing a vitreoretinal procedure for this particular patient. Pupils usually should be brisk, except if they have a detached macula or if the retinal detachment exceeds more than 2 quadrants. If there is a RAPD significant, it can be also because of a retinal injury secondary to trauma or in a cases of intraocular tumor. Usually intraocular pressures are low. In a rare cases, that is Schwartz syndrome, there is a raised intraocular pressure because of the inflammation which happens because of the photoreceptor outer segment which causes uveitis. Indirect ophthalmoscopy is the only way to assess the detail of any retinal detachment, and that too along with a scleral depression. Yes, today we have ultra-wide field fundus photography, which might make indirect ophthalmoscopy with depression obsolete in coming days. But frankly speaking, as a surgeon, this is the only way where you're own comfortable and you can 100% be sure where is the break in a case of a detachment, where is the lattice and all those things. In a tractional retinal detachment, you need to understand what is the location of a fibrovascular proliferation, what is the amount of traction it is causing. And in an exudative detachment, you look for shifting fluid, you look for signs of inflammation, and in certain cases, mass lesion. Sonography is usually restricted to hazy media, or sometimes when you have a doubt whether it is a PVD versus a RD, sometimes in an exudative variant to evaluate a mass lesion or to assess a chorioretinal thickness when you are having a certain exudative type of a detachment. The basic differentiation when you have is between the two basic things is retinal detachment versus posterior vitreous detachment. How do we differentiate on an ultrasound? The reflectivity of a posterior vitreous detachment is low, it disappears with low gain, and it is highly mobile. And if it is an incomplete PVD, it would have a single point attachment at the optic nerve head. While a retinal detachment is highly reflective and it is slightly less mobile compared to PVD, and at the optic nerve head, it will be 2-point attachment, not a single point attachment, unlike a PVD. B-scan also helps you in picking up shifting fluid. You can see this is a B-scan done in a supine position where you see the fluid is predominantly located in and around the posterior pole. While in an erect position, the fluid has moved down because of the gravity. And you can make out a convex configuration. A choroidal detachment you can see, well, here, why do we do a B-scan? Basically to do tissue differentiation. What is the type of a fluid over here? You can see a hemorrhagic, which is more reflectile, which is equilucent. It is mostly a serous type of a detachment. So coming to the first variant, that is exudative retinal detachment, as I already said, there is an exudation from retinal vessels and choroid into the subretinal space. And here it is typically convex configuration, surface is smooth and not corrugated. The most important feature over here is shifting fluid. And the treatment here is specific to the cause. What are the causes? It can be tumors, inflammation, bullous, central serous chorioretinopathy, iatrogenic, and all this elicited over here. But let us move through a few examples. This is a case of a bullous, exudative type of a detachment with a mass lesion, and you need to do B-scan, and which can tell you by tissue differentiation the type of a tumor you are having. Here, this is a case of a hemangioma. You can see orangish hue over here with a serous detachment. This is a trabeculectomy patient having a hypotony leading to choroidal detachment over here. Now this you can see posterior pole detachment over here, some vesicle-like structures over here. At the same time here in this second picture, you can see an exudative type of a detachment. When you do an OCT and an angiogram, you could find a stipple fluorescent starry sky appearance. This is because of VKH. In these cases, you need to look at the disc as well, where you might see it to be more hyperemic and you might in the vitreous see few cells. While in this variant, if you can see, as the OCT, you will see more bumpy, more septas over there. And this was because of a posterior scleritis. Ultrasound here was a diagnostic thing, while here angiography and OCT help you in making a diagnosis in these cases of exudative detachment. Now this is a posterior pole detachment over here. You do an OCT and an angiography was here to catch. It was a central serous chorioretinopathy. And in fact, this patient was on steroids. The moment we stopped the steroid, this is 2 weeks later, the fluid came down. So whenever you see an exudative detachment, do think about central serous retinopathy. Now, this is a case who patient presented with exudative retinal detachment in inferior quadrant with multiple soft exudates. On an angiogram, you could see multiple fluorescence over here. And this patient, when we did a simple blood pressure test, he had a high 200 by 110, and it was a case of a hypertensive choroidopathy. The basic differentiation which you need to do in a case of a exudative retinal detachment where the treatments are just mutually conflicting is a case of a CSR versus a VKH. And how do we differentiate these two variants? Here you need to remember that VKH happens because of inflammation, the disc is hyperemic. You get a starry skies pattern on an angiogram, and an OCT you might see subretinal septa and folds on RP. And here the treatment is steroid and immunosuppressives, while in central serous retinopathy, you might get multiple leaks like this in plot or smokestack appearances. And here you need to stop the steroid, and that is how you need to differentiate with the help of these clinical features. Now, coming to the management of exudative detachment, you naturally need to treat the cause. If it is inflammatory, treat the inflammation with the steroids, or if it is a mass lesion, accordingly you need to treat. Now, coming to the second variant, that is tractional retinal detachment, as the word means, it can happen either because of a proliferative vascular retinopathy or because of penetrating posterior segment traumas. And the sign here is concave configuration, and the highest point of elevation, which is usually limited, is at the site of vitreoretinal traction. And it is less mobile. And most importantly here, you can see a signs of vascular retinopathy in that eye as well as in the other eye, especially in the diseases which are bilateral like diabetic retinopathy. Important is there is no break, there is no shifting fluid. So tractional retinal detachment, basically you need to classify into extramacular. You can see a fibrovascular tissue over here, but on an OCT, this tractional point is quite away from the fovea. So this extramacular traction can be washed by doing a pan-retinal photocoagulation and trying to do an anchor laser to prevent its migration further to hold back. And this is another variant of tractional retinal detachment where the fibrovascular proliferation is pulling even the macula, as you can see on the OCT over here. And this is a surgical case where you need to do vitrectomy. As I said about the extramacular traction, you need to do anchoring laser. Anchoring laser means you have to prevent that progression towards the macula, though it cannot be theoretically much proved, but it can be stopped for a while. But along with it, you need to also complete the pan-retinal photocoagulation. Indications of vitrectomy: once you have a traction on the macula, you need to operate him, or a progressive tractional retinal detachment which is threatening macula, or a patient who seems to be non-compliant, or a tractional retinal detachment which has progressed into combined, they need some surgical indication. Now coming to the most common variant, that is the rhegmatogenous retinal detachment. Here you have a convex configuration. As I said, the fluid usually over here extends up to the ora serrata. It is usually not located to the posterior pole. And here the blood vessels appear darker at the retina and there is a loss of choroidal pattern. This is again a case of a rhegmatogenous retinal detachment where it is not extending to the posterior pole, but it is because of a macular hole. Very rare variant, but it does happen. The basic differentiation here, you need to differentiate the detachment is from retinoschisis, which is a common differential diagnosis. And how do you differentiate? Retinoschisis is usually present in inferotemporal quadrant. Their breaks are present in outer as well as inner layers. It is less mobile. And most importantly, laser uptake. If you're not sure whether it is clinically, whether it is a schisis or not, a laser uptake test is done. And importantly, in a case of a congenital retinoschisis, you will have macular involvement where you can see schisis even in that cases. So this is a case of a schisis along with a retinal detachment, and this is the OCT, how it helps you in differentiating. You can see the schisis even in the macular region, and so your diagnosis becomes more pinpoint that this is a case of a schisis along with retinal detachment, warranting a surgery. Plain retinoschisis does not need a surgery. So how do we manage a case of a rhegmatogenous retinal detachment? The three principles are to produce a chorioretinal scar around the break. Second is to relieve traction. And the third point is to approximate the separated layers of the retina. You have to do a good indirect ophthalmoscopy to find out the break so that you can create a chorioretinal scar. But in event, if you are not able to make out a break, then Linkoff's rule comes to your hand. And here, this is how, by this rule, you find out where is the most probably likely site of a break when you are not able to see. It depends upon the configuration of the detachment. I will not go into the details of this particular thing. So how do we close the hole? We could do it a retinopexy. Retinopexy, that is creating a chorioretinal scar. It can be done either with the help of a diathermy or with a cryo or with a laser. Where do we create a retinopexy? To all the breaks and predisposing lesions in detached retina, as well as predisposed lesions like lattices, even in the attached retina. In event, if you are not able to see the predisposing lesions or if the breaks are not visible, in that case, the cryo or the pexy is done end to end. That is called in bad media. Diathermy gives the strongest adhesion, but no longer used because of the scleral shrinkage and the injury it used to cause. Cryo is the way we use. It can be used transscleral, transconjunctival, and the effect physics. The principle which is used is a Joule-Thomson effect, and the critical temperature of the tissue reaches around -2.2 degrees here, which leads to freezing of that cells, leading to dehydration, leading to sterile chorioretinitis. And this is how it works. If you go inside, you can create a chorioretinitis, or with a LIO, you can do a laser pexy. You can use any of this type of a green lasers or anything, and you can use. So what is the strength of the adhesion and how early can we get an adhesion around the break? The break location cryo can be used in anterior break, posterior breaks. It is difficult to reach out. The strength of the adhesion is best with the help of a diathermy. And onset of the effect, if you can look, is earliest with the help of a diathermy, while with the help of a cryotherapy, it is delayed by 7 to 10 days. Once we create a chorioretinitis, now the next job of a retinal surgeon is to approximate the two separated layers. It can be achieved externally with the help of a scleral buckle or with any of this like Linkoff's balloon or a temporary buckle. Or you can go inside and push the retina towards the choroid or the RP, either by pushing a gas inside a non-vitrectomized eye called pneumoretinopexy, or you do a vitrectomy along with a tamponade. So Linkoff's balloon, this can be used anywhere around it, but the only delimitation was the exact positioning had to matter. And other thing is, it needed a breaks in 1 or 2 quadrants of clock hours. If it is more than that, Linkoff's balloon was not possible. Then came a better variant of it that is called temporary scleral buckle, where Nicholas has described in 2013, which can cover the more areas of retina. And here it can be used even in inferior retina detachment or inferior breaks, I should say. This has the advantages of temporary scleral buckle, but the gold standard for us is still the scleral buckle. If you go inside the eye, you can just push a gash, and if it is a limited retinal detachment, you can do a pneumoretinopexy. The principle is that bubble larger than the break leads to surface tension, and buoyancy of the gas prevents it from slipping through the retinal break, which pushes the detached retina against the RP. Second thing is, it blocks the hole because of the surface tension of it, and that prevents the current of the fluid current moving inside into the subretinal space. You can use various gases which has various expansive duration till which it can be maintained. And the indication is that here the retinal breaks has to be typically within superior 8 clock hours. That is from 8 o'clock meridian to 4 o'clock meridian. And the break should be single, or even if there are multiple breaks, they should be within 1 clock hours. And the other thing is, this patient should be ready to undertake a position. You have to give him a prone position, or depending on the site of a break, you have to give accordingly the position for this particular patient. As I said, the gold standard for a simple retinal detachment without a PVR like this is scleral buckle. Here, first you create a cryoretinopexy around it, and then indent the sclera towards the detached retina. And how does it work? This is the principle how scleral buckle works. It can be either by explant technique or implant technique, where the buccal materials placed after dissecting the sclera. And these are the various configurations which we use and the indications where we use. And this is a short video. I will just run through for the sake of thing. You cut the conjunctiva, you tag the muscles. After tagging the muscle, this is an explant technique where with the help of a pre-placed non-absorbable suture, the buccal material is placed, and that after tightening leads to indentation of sclera. As you can see, we are tightening it and then closure. Pars plana vitrectomy. When do we do in a case of a detachment? When media opacities are high, posteriorly located breaks, retinal detachment with giant retinal tears or macular hole, advanced PVR, and nowadays we even talk about primary vitrectomy for all types of rhegmatogenous retinal detachments. These are the benefits. You have an improved view of retinal periphery. You can identify each and every retinal break on the table. You can relieve the traction, which is one of the most important cause. In a scleral buccal, you push the sclera towards the retina, but you cannot actually relieve each and every traction part of it. And this is the principle of pars plana vitrectomy. Again, you treat the break and with the help of by creating PEGC, you relieve vitreous traction, you create chorioretinal adhesion, and then put a tamponade till the adhesion takes over. And these are the steps of vitrectomy where you do various steps of it. The most important step during vitrectomy in this cases is is doing a posterior vitreous detachment, which is an art in a detached retina. And you can see here we are doing a posterior vitreous detachment, which is key important factor in achieving a success in a case of a retina detachment. And so you have to be patient over here. Base excision should be done in most of this patient because base, if you leave a lot of vitreous, it leads to proliferation and leads to redetachment. Second thing is, if there is as I said, in a case of PVR, there can be various components of traction which can be anteroposterior, circumferential, and for that you need to do membrane peeling as well as ILM peeling. And once that is done, you need to approximate a detached retina. The approximation is done either with the help of a perfluorocarbons or with the help of a air. This is the advantages of when do we use perfluorocarbon, when we use advantage of air is that the advantage of PFCL is that it is excellent. You get excellent visibility, you get but the field of view remains same. There is no problem of pupillary miosis. Repositioning of the retina is more accurate. And in the event, if you need to do posterior retinotomy, it does not extend, or unlike if you do it under air, which tends to enlarge. And then after approximating the retina, that PFCL is removed, and then you do a retinopexy either with the help of an endolaser or with the help of a cryo. And after doing a retinopexy, a permanent tamponade is put either in the form of a gas or a silicone oil. Here we are putting a silicone oil in this particular video. The advantages of silicone oil is that you can have a prolonged tamponading effect. Post-operative positioning is needed, but not necessarily very strict. Early visual rehabilitation, and there is no restriction on air travel. Gases, if superior breaks are there, and PVR is not significant, gases is a preferred modality of treatment. This is the comparative chart. When do we use? What are the advantages? When do we use of gases versus a silicone oil as a tamponade? And this is a short video of, again, vitreous surgery, a case of a RD with a PVR. Here the PVD induction is happening with the help of a cutter. Now we have achieved a PVD, that is posterior vitreous detachment. Vitreous being cut, trimmed further after PVD induction. Membranes being peeled over here. You can see this very strong adhesion. This must be a young case where the membranes have been removed. And then after relieving all the traction, PFCL is being done to flatten the retina. And now the peripheral vitreous skirt is being cut. We are removing even the peripheral vitreous. And after doing a PFCL, we are doing a PFCL air exchange and then an endolaser for this particular patient, and then a tamponade. That ends the surgery over here. In a case of a tractional retinal detachment, besides this, there are fibrovascular proliferations or membranes on the surface of the retina, which needs to be cut with the help of various techniques, either by peeling, segmentation, or delamination. Here, with the help of this, I'm pulling of the membrane with the help of a forceps. This is a complicated, combined case of proliferative diabetic retinopathy with a tractional retinal detachment. And you can see with the help of a vitreous cutter, now we are cutting, trimming all the membranes so that the tangential anteroposterior traction, whatever that membrane is causing, needs to be relieved. And once that is done, then you need to laser the rest of the area because it is a case of a vascular retinopathy, and cut off the ischemia. And this is how we tackle this. So retinal detachment, one needs to remember that once you have a floater and flashes, definitely do an indirect ophthalmoscopy along with a depression, and based on the type of a classification, if it is a rhegmatogenous retinal detachment, do refer it to a retinal surgeon who will do a job on the basis of principles which we discussed earlier. Now, thank you.
Thank you very much, Prashant. Dr. Lalit, is there anything more to discuss on retinal detachment?
I think you should have given him some more time. I think the way
Gopal,
he
I'm
built
through.
Yeah.
The way he built up the entire story, I am very happy that this lecture was tailored for postgraduates and comprehensive ophthalmologists.
Yeah.
And I'm happy that he paid a lot of emphasis on
Am I audible? Hello.
I am happy that he paid a lot of emphasis on non-rhegmatogenous RD also. And regarding reg RD, only point I wanted to make was that only point is he speaking or?
No, Prashant, it's okay.
Lalit sir, your mic is off. Can't hear anything.
Gopal, can you hear?
Yeah, I can hear, sir.
We can all hear, sir. We can all hear.
Okay. Only thing I wanted to make was, although he said historically, to my thinking, Linkoff balloon and pneumoretinopexy have taken a backseat slightly. They had their good time, but today they are used very infrequently because success rate of these are very, very good. I would say that they are now history because nobody wants to have success rate less than 90-95%. Buccal still has a role. People should not forget that Buccal still has a role, especially in young patients, phakic patients, dialysis, and wherever buccable, young patients should be, preferably buckled. And very nicely suggested that indirect, you see, people are talking of heads-up surgery. A lot of our residents, they want to see everything on the table, but I would still, maybe an old-timer, would still like to evaluate all patients with indirect. And with advances in so many techniques, I think today we can very confidently say that all detachments are settleable, at least anatomically. Meena, Giridhar, or anybody else?
I think you have covered everything.
Please carry on, sir.
I don't think anything more.
Okay, I think we are on the last talk now, Gopal.
Yeah, we are on the last talk. I would invite Dr. Rajesh R. from Shankara, Bangalore, who is a young and dynamic vitreoretinal surgeon. Rajesh will be speaking on complications, retinal complications of cataract surgery. That will be the last man batting. Over to you, Rajesh.
So can you see me? Hello?
Yes, you can see.
You can share your screen, please. No, you are muted. You are muted.
No, sir.
Yeah, now it's right. Now we can hear you.
So can you see my slide?
It's on the way.
No, we can't see your slide.
Not yet, Rajesh.
I'm trying, sir. Sorry.
I'd like to say that it has been a very long day. So there is a lot of thought that we power packed a lot of info together, but it's once in a while that we get all these star teams here together. And why not take the opportunity and build up the Rajesh? You are doing right.
Sir, I'm trying, sir, but I don't know why the screen is not sharing up.
I see. Rajesh,
hats off to you and the Sai Kumar and the entire COC for this idea.
First, you open the presentation in your desktop.
Rajiv, can you guide him, please?
Don't try to open after sharing your desktop.
Sir? Yeah, I have...
Minimize your Zoom.
Okay.
Open your presentation, put it in the taskbar. Then when you want to share, it will show you which one to share.
So I minimized my Zoom. My slide share is there. I can see that, but you cannot see, sir, still?
Not yet, not yet.
Rajesh.
Yes, sir.
Rajesh, can you send the slides over, mail it over to somebody? Is it a large file?
No, it's not that large, sir. Not that large. Can I send it across?
No, Gopal, in case he can exit and then join again.
We can just guide him now, Gopal.
Better that somebody else opens it.
Sir,
do you see the share screen button, the green one, down
yes,
bottom?
Sir. Yes, sir. It's there,
press
sir.
that. Press that.
I have pressed it, sir.
What are the options it's showing? Is your presentation there in that list?
No, sir.
So you have not opened the presentation.
You can share. You can share the entire screen if you want. Share screen.
There, no?
Yes.
Or
I think Gopal, let him exit and come back. Even I had to do after my presentation. I was not suddenly I became.
Yeah.
Sir, I leave it. Come back, sir.
So can you see a icon called files?
It's like here.
You open share screen. You have
yes, sir,
you see an option called files.
No, sir, it's not showing that.
No, on the top.
On the top.
Basic advanced files.
Basic advanced
No, sir.
files.
No, sir, no. It's showing your entire screen, application window, and it's soft. That's it.
Yeah, entire screen you share, no? Entire screen.
That's what I've done, sir. That is what I've done.
Yes, now it is coming. Now it is coming.
Yeah, now it is coming.
Now you can open the PowerPoint.
Yeah.
I'll just do that, sir. Yeah, right now, sir? Is that okay?
Yeah,
yes.
Correct.
Correct.
Is that okay, sir?
Yeah.
Yeah, thanks a lot, and sorry for the delay. So thanks Gopal sir for my topic. So it's given me to cover retinal complications of cataract surgery. I'll try to see what justice I can do in the next 10 to 12 minutes. So broadly, I've classified this into two, that is surgery related and post-operative. In surgery related, the most common being is the block associated, that is the globe perforation, which occurs either with the peribulbar or the retrobulbar block. Retrobulbar block has gone into a back stage, but even with peribulbar block, we might have block associated issues. The most common being just a break. The other issues might be vitreous hemorrhage, which may resolve or may not resolve. Other complications include retinal venous occlusion and retinal arterial occlusion, or a total retinal detachment. So in the intraoperative, we have other complications such as nucleus drop, or when a nucleus drop occurs, when the surgeon goes for a retrieval, he might create breaks or a giant retinal tear, which might lead up on to retinal detachment. The third in the surgery-related complication, which I would like to mention, is a supracoidal hemorrhage. If there is a sudden decompression or a sudden prolapse of the nucleus outside, which is usually associated with SICS, there might be a sudden collapse of the pressures, or even in combined surgeries such as glaucoma associated with cataract surgeries, that might cause a sudden collapse of the eye and the improper pressure, which might lead on to supracoidal hemorrhage. In the post-operative complications, there are several, but to mention a few associated with retina, the patient might have a pre-existing conditions like diabetic retinopathy, which might get exacerbated with the post-operative period. there is Irwin gas syndrome. There is posterior dislocation of the intraocular lens, which might be immediate or later. Drug-related complications. Various drugs have been associated with retinal conditions such as vancomycin, which has been widely used previously to prevent endophthalmitis, which is associated with hemorrhagic occlusive retinal vasculitis. Gentamicin associated, which might cause retinal infarction, macular infarction. In fact, Triphine blue, when used to stain the anterior capsule, might run into the vitreous and cause issues as far as visibility is concerned. PCI related is also quite common, which causes vitreous loss and secondary rheumatism, retinal detachment. Choroidal detachment usually associated with SICS, which has wound leakage. So let us go into one of these, each of these, and try to cover up a few of the topics associated. So first is the surgery related. So globe perforation, it is quite rare in experienced eyes. It's more common when the axial length is high, that is in myopic eyes, or patients who have posterior cephaloma. So using of a very small gauge sharp needle or a large blunt needles, both might be a harbinger to cause globe perforation. So you should take adequate size needles and sharp needles, single use, and we have to place it in proper positions to give the retrobulbar or the peribulbar injections. With the conversion into peribulbar, the incidence has significantly reduced. So as far as recognition of the globe perforation is concerned, usually there is a tugging movement. So once you move the needle, the eye also tends to move. There is severe pain, which is complained by the patient. There is severe hypotony, loss of red reflex if you are looking directly into the eye, or if at all, sometimes if we enter into the globe, causing injection of the anesthetist agent into the eye, it might turn into a stony hard eye and cause an ocular explosion also. So the presentations might be variable. I'll cover as much as possible. The commonest or the least possible side effect is a small perforation, which is present in this. We had the chance to run a SSOCT because it's not never so posterior. But in this case, you can see there is a full thickness perifoveal retrocoroidal breach with structure of the Brooks membrane. Area of hyperreflectivity depicting a intraretinal hemorrhage along with a supratemporal subretinal hemorrhage was noted, and this we documented and published our first paper in the SSOCT analysis of the perforation. Not all the other issue being a small flap which is raised, which might threaten to cause retinal detachment. In these both the cases, you see there is a small perforation with a lifted flap, so we could get away by just doing laser and observing the patients all along. Not all patients are so lucky. Sometimes they might go into non-resolving vitreous hemorrhage. You can see I have two images of the same patient. Arrow marking on my left side is the gas. This patient had got a perforation in the superior nasal quadrant with a non-resolving vitreous hemorrhage. Post-vitrectomy, we have put in a gas tamponade, which you can see as the horizontal line in the left image, and a small amount of retinal hemorrhage in the right, showing the perforation site. Other known issues which might happen when a perforation occurs is a retinal vein occlusion, a retinal arterial occlusion, as well as a retinal detachment. It might be a localized retinal detachment or a total retinal detachment if presented late. Management, never to mention that prevention is the best way to not venture into this kind of a condition. Early recognition, doing an interophthalmoscope, preferably just after the block or a suspected perf is there. Vitrectomy if there is a retinal detachment or a non-resolving vitreous hemorrhage is there. Medical legal cases, it's better to confront the patient and explain him an entire procedure and be with him whenever such complication occurs. Intraoperative, another complication is a nucleus drop when the PC opens up due to excessive hydration, or if there is a congenital PC posterior polar cataract, there might be a sudden collapse of the nucleus into the posterior segment. This is a case where I'm managing it using a phacofragmentation. Phacofragmentation is basically a posterior version of phacoemulsification, but the only difference is it doesn't have a sleeve and the support of the nucleus is not there. So it's basically moving in the mid-vitreous cavity. So we have to lift it up into the mid-vitreous cavity and try to emulsify the nucleus into multiple pieces and take it with the support of the light. Or if you have a chandelier, you can take a bimanual method of eating up the nucleus also. In this, I was quite lucky because the nucleus sclerosis is not that very dense, so we could easily remove it up. So once the nucleus, before doing a phacoemulsification of phacofragmentation of this nucleus, an anterior and core vitrectomy has to be done. The posterior vitreous detachment can be done before or after, depending upon the surgeon's preference. So another condition where another method of removing this nucleus is called as impaling, where we do a scleral tunnel. I have represented images because of short of time. So we do a pre-placed scleral tunnel. We make the standard ports for the pars plana vitrectomy. We go in, if there is a concomitant retinal detachment, the break has to be identified and localized. So the nucleus is basically impaled using a sharp 20 gauge NVR needle, which is buried deep into the nucleus and lifted up into the iris plane. Once lifted into the iris plane and stable, we can make an entry to the pre-placed scleral tunnel and remove it through a wire vectors. In this particular case, I wouldn't prefer, I've just shown this image because I had this video. If a retinal detachment is there, it is preferable to do a phacofragmentation rather than doing an impaling. If the posterior pole is absolutely fine, vitrectomy is completed, then this can be done in cases where the nucleus sclerosis is quite dense and phacofragmentation might cause other complications like as wound burn. So sometimes another complication which as retina surgeons we might face is condition like this, where the operating anter-segment operating surgeon has ventured much way posteriorly to retrieve the dropped nucleus, and in the method he has used a wire vectors which has scraped the retina apart. So here the PVR grade B has already started up with rolling of the edges and using perfluorocarbon to stabilize the posterior pole and to roll out the layer. Once this is achieved, we can do endolaser to the edges of the break and then put an endodampener like silicone oil to stabilize out the retina. So the third complication which is surgery related is the sudden decompression of the eye, which might cause suprachoroidal hemorrhage. Suprachoroidal hemorrhage usually is pretty difficult. We usually manage by giving steroids and relieving the pain, waiting for about 5 to 7 days, doing serial ultrasound to make sure that the blood in the choroidal space has liquefied. Once it is liquefied, we have to assess the retinal condition, and based on that, we have to take up for surgical intervention. If the choroidal detachment is less, it might regress, but in majority of the condition, it requires a choroidal drainage. Here, I'm putting an AC maintainer and then doing a stab incision of a partially entry into the suprachoroidal space. You could see the amount of blood that oozed out of the suprachoroidal space into external. So this patient had a concomitant retinal detachment, which was taken care once the choroidal detachment was settled. In post-operative, come out to the post-operative complications. Some most common being an exacerbation of a pre-existing condition. This is because any surgery, especially a cataract surgery, causes a progression. Excessive inflammation is induced, which might cause a progression of the pre-existing conditions, such as diabetic retinopathy and chronic uveitis, to mention a few. So methods to prevent this as a anter-segment surgeon would be to use minimum phacoemulsification energy, using running less of fluid into the intraocular space and avoiding iris trauma. So just to quote an example, this is a patient where post-operative, the patient was sent for unidentified vision loss. He is a known diabetic. If you look at the posterior pole, it doesn't look much of a problem, but there was on slit-lamp biomicroscopy macular edema. But when we did an FFA, you could see the amount of inflammation associated edema which has come up. So there's a gross CME. This was post-cataract surgery induced. So coming to the commonest topic, which is usually covered in the post-operative complication, is the Irwin-Gass syndrome or a pseudophakic cystoid macular edema, which was first described by Irwin AR in 1953 and later defined by Gass et al. The inflammatory insult of cataract surgery is because of the release of the inflammatory mediators such as prostaglandin and cytokines, which leads on to breakdown of the blood retinal barrier, which increases to the vascular permeability and fluid leakage. So there are two methods. Clinical examination, it is quite rare to amount to about 0.1% to 2.3%. But if we start doing an FFA and a spectral domain OCT in most of the cataract surgery patients, we have seen that subclinical such kind of Irwin gas was found as much as for 41% of the patients. But that's subclinical, since patients don't present with much of a problem and they do heal up over a period of a week to 2 weeks. So it doesn't come into clinical notice. So the type of surgery involved also determines the extent of inflammation, thereby determining the Ewing gas syndrome. So obviously ICC had a more incidence as compared to ECC and phacoemulsification. Flax as of now is the safest method to prevent such kind of inflammatory process and associated Ewing gas syndrome. Usually presents 4 to 6 weeks post cataract surgery, but in rare condition might present even months or years later after the surgical intervention. So this is a typical case who presented 1 month post surgery with non-resolving macular edema and vision loss. So suboptimal visual acuity. So when we did a FFA, we could see a petalloid pattern and the OCT showing a outer plexiform layer thickening in this patient. So as far as management is concerned, 80% of them do spontaneously recover. But if at all a patient have an acute IGS which is about 2 months old, the first line therapy would be just given topical NSAIDs, which might be a ketorolac or an epafenac, and wait for the resolution for approximately about 6 to 8 weeks. After 3 months of the acute onset, if the patient presents non-resolving, then better to add upon steroid to the NSAID which has been already added. After 4 months, if the edema doesn't come down, then it's better to add intravitreal triamcinolone acetonide, which is for more than 2 months. If the patient has a chronic, which is more than 2 months, better to start up and follow the same step ladder pattern with the NSAID and the steroid as the first treatment of choice. In this patient, you could see a post-cataract surgery within a matter of 10 days. The patient presented with vision loss, OCT showed macular edema, waited for 2 weeks, and then the edema increased further with coalesce of the cystoid spaces, due to which IVTR was given and it completely resolved. And let us come to the drug-associated drugs which are commonly used, which were commonly used in cataract surgery and that caused complications. One of the commonest and the most horrible complication was HORV, that is hemorrhagic occlusive retinal vasculitis. Previously, vancomycin was generally used to prevent postoperative endophthalmitis. So this developed as a complication of intracameral vancomycin, usually presents on the first or second week post intracameral injection, leads to painless and progressive vision loss, sometimes even bilateral when bilateral cataract surgery was done simultaneously or on the same day. Relatively mild anterior chamber and vitreous reaction, which distinguishes this from any other viral kind of retinitis infection which we can note in these patients. Diffuse microvascular occlusion, extensive intraretinal hemorrhages are a notifying factor in this problem. FFA shows stark non-perfusion of the border of active vasculitis. So negative extensive intraocular and systemic workup, as I had already mentioned, most of these patients were previously confused for viral retinitis. Not much of significant treatment has been associated with this. Corticosteroids have helped to a little extent, but not significantly. Another commonly used drug was gentamicin, which was given as a routine in subconjunctival spaces, sometimes inadvertently entering into the vitreous cavity. Gentamicin is one of the most toxic aminoglycoside, which leads to macular ischemia and infarction. Superficial retinal hemorrhages with cortical spots, arterial narrowing, and venous bleeding are known to occur in this condition. FFA shows severe macular vascular non-perfusion. This leads to profound vision loss, reverse irides, NVG, and optic atrophy in the later stages. Trifan blue is interesting that even I came to know once this topic was given. So basically what happens is an inadvertent posterior flow of the Trifan blue occurs when you stain the anterior capsule. So usually noted in conditions where there is a zonular dialysis or a capsular stain like the Argentina flap, where the Trifan blue runs through the zonules into the vitreous cavity, most commonly seen in patients with pseudoexfoliation and capsular runaway. Causes media opacity and vision loss, but it is temporary. Since it's being a benign, it clears within a matter of weeks together. So this is one classical photo which I could pick up. This is from the internet. So you can see that the angiotensin flap which has occurred and the dye which has gone posteriorly and completely filled the vitreous cavity. The last of the complication is the vitreous loss associated and the rhegmatogenous retinal detachment with it. So vitreous loss occurs as a consequence of posterior capsular rupture. Acute posterior vitreous detachment occurs in these patients within a matter of week to month, and this causes a peripheral break, more so if the patient has a peripheral degeneration and myopic eyes like lattice, holes, white without pressure, which might cause a chain retinal tear also. So this is a example of such a patient who had a complicated cataract surgery, who had developed a superior temporal agent retinal tear. But the good part was that the retinal detachment had extended only to the superior arcade, and it was taken up for surgical intervention. So I've just not taken up the video, but the steps itself in the interest of time. So the first step would be to do an anterior and core vitrectomy, delineate the breaks and the GRT, and clearing the vitreous all around this break. So once this is done, trimming of the GRT edges and freshening it up, cauterizing to make sure that we identify this break. So PFCL is injected to stabilize the posterior pole and prevent the extension of the retinal detachment into the macula. So once this is done, the retina is attached. We do a air PFCL exchange, do the endolaser and silicone oil tamponade to stabilize the retinal detachment. Thank you, sir.
Thank you very much, Dr. Rajesh. Can you stop sharing?
Yes, sir.
Lalit, sir.
Must compliment Rajesh for the patience he has had to describe so many complications. Believe me, you see, it's not easy in span of 10-15 minutes to describe also so many. But hats off to you, Rajesh, for elucidating so many. But just to summarize what you said, I think globe perforation should be avoidable by and large. If you are, if your eyes and ears are open, by and large should be avoidable. But if not, then I think it manifests as hypo and hypertony. Either way, it can manifest. Management by and large is not so different than the other. Sai Kumar, you want to say something?
Yeah, I mean, I think I am the only pure cataract surgeon in this group. So just one or two comments. I think Dr. Rajesh made a very valid point that in patients where you manipulate the iris more, the incidence of CME is definitely more. That is my experience. The IFIS cases where the iris flops around.
We are coming to CME. We are just talking of globe perforation initially.
Oh, sorry.
Yeah. So globe perforation. Coming to drop, I think Rajesh made a very valid point that you see, by and large, the message for all the anterior segment surgeons is please do not fiddle with vitreous and do not put any Vectis-like instrumentation. Previously, you see all the trolley will not be completed without Vectis, but today Vectis should not be there in the trolley at all, because you see the kind of tear which you showed, big tear very close to the macula, again was a scenario not to be seen nowadays. And not phaco-frag is the best answer. Rarely impaling may be required, but by and large, most of the nuclei are amenable to phaco-fragmentation. CME, I'll request Sai Kumar to speak, but suffice to say that NSAIDs are the best agents, and rarely supplement on tricot. Supplement on tricot will be required. I have rarely used, I have in fact not used Ozodrex or intravitreal transferrin also. Most of the patients will respond to subtenon injection. And HORV and trypan blue, I was slightly surprised because you see intracameral vancomycin causing so much of toxicity. And I know all these reports, but we inject intravitreal also, and I don't know what other people see, but intravitreal vanco we inject, and even trypan blue, you see reti blue we inject to stain ERMs. Haven't seen much. I will have the opinion of the house. Yes, Sai Kumar, now you can comment on CME.
I was just mentioning about the cases where you manipulate the iris more. Incidence of cystoid macular edema is definitely more. Cases where there is IFIS, cases where you put iris hooks for small pupil. So I think that was a point that is very important. The second thing is, in some patients, along with the CME, you have a mild anterior segment inflammation. You have some faint DM folds. I think in such situations, you might request some steroid also. Not that every CME you treat only with Nepafenac or NSAID initially. In some patients, you may have to add steroids in the initial stage itself. And I think that it's very important. And I think vancomycin, sort of almost all of us are now using intracameral moxifloxacin, and not much of vanco. So I think that is not we may not see such complications. Yeah.
Yes,
Rajesh. I had the same doubt, like we give left and right for all endophthalmitis, so we don't end up with having HORV. But why was this? So I went back to the 12 case, which was initially reported. The dosage was a little of an issue, sir. It was almost 3 times the dosage that we give for intravitreal, which was initially, given for the prevention of endophthalmitis in the cameral injections, which was originally noted by. So maybe the dosage was the related one, sir, rather than the combination of use of ointments.
Giri, final comments?
Sir, unmute, sir.
Muted.
I think Rajesh covered everything very well. I would like to only say that probably the incidence of post-surgical complications of cataract surgery is definitely much less than what we used to see many years ago, especially nucleus drop. I think the number of cases we see now is far less than what we used to see many years ago. And there is an exponential decrease. I think the most common surgical complication we are seeing now is dislocated IOL or decentered IOL. I think that's the most common surgical complication of cataract surgery now that we handle in practice.
Surgical expertise has improved so much. Yes, Dr. Meena.
My take-home message is for the novice cataract surgeon. In the event of a posterior capsular rent, do not panic. Attempt to remove the nucleus only if it is visible and in an accessible area in the pupillary space. Do not fish for the nucleus, as has been very elegantly explained by Dr. Rajesh. And do a thorough cortical cleanup, do a good anterior vitrectomy, reconfirm your vitrectomy using TA, and see to it that your wound toilet is proper. Put in an IOL only if you have enough visibility to access the amount of capsular zonal support that you have. And whatever options that you choose to visually rehabilitate the patient, whether it's an anterior chamber IOL, iris suturing, iris fixated IOL, iris claw lens, sutured or sutureless scleral fixation or intrascleral haptic fixation, the final visual result is almost similar. So whatever works best in your hand can be done. Put in an IOL only if the retained lens fragment is of a grade that can be managed by a VR surgeon using a fragment tool. And always have a friendly VR consult come in to see your patients postoperatively also. And if you have somebody to do the surgery in the same sitting, that would be best for you and for your patient also.
In the same house, it is the best, no?
Chakravarti Eye Center has no issues.
Best if the surgeon is in the same house.
So, nearing the fag end of our, day today, we are only halfway through. Tomorrow there is another full day.
Three more to go.
Yeah. So midway through, we want all the faculty photograph. Neha has come especially for that.
So Sai and Gopal, how happy you are after 6 rounds?
We are extremely happy, sir. We didn't think we'll get so much of the best faculty in the country. We have got our YouTube streaming, YouTube live views, Facebook views have run into thousands, and none of the speakers would have ever got such an audience had it been a physical meeting. So that we have sort of facilitated such a meeting. We are extremely happy, and we hope that same thing continues tomorrow also. And our technical team, I think Rajiv is slightly relieved today evening. And John and Prashobh, I think morning there were some hitches in the initial Zoom platforms, but looks like it has been sorted out. And we are keeping our fingers crossed that the same thing works till today, till tomorrow night.
We were just looking for a faculty.
Rajiv, I hope you are making the YouTube link available for the people who have not been able to.
Yes, sir. It will be available, sir.
Yes, sir. We will splice these videos. We will splice these videos into individual lectures and send it.
That will be a good resource. I think we need to thank the COC for this magnanimous job, mega job, great job, and where the thrust has been primarily on teaching rather than lecturing. No, Gopal?
Absolutely, sir. Thank you for drilling that into my head.
Yes, back.
Because 7-8 minute talk plus you have been liberal for discussions also. You have allowed the reasonable good discussions. And I thank Giri and Meena.
Speciality of Kerala Ophthalmic Society meetings, Kerala meeting.
Sure.
Sir, please don't leave. We'll have a group photograph, sir.
Okay. Giri?
Shall I enter?
Giri is standing up. I think
you can